Dr. Dan Oromisi. Please kindly put your hands together for him. We have as one of our assessors, Dr. Nwafo Mori. Please put your hands together for her. We have Pharmacist Luca Augustine. Pharmacist Hawa Bature. Pharmacist Hakim Aina Alagbala. For the abstract presentation, we have these assessors. We have Pharmacist Ayuba Abdurazak. Please put your hands together for him. We have Pharmacist Akikumi Jacob. We have Dr. Henry Osain. And Dr. Daraka Abubakar. And my humble self, Akelikun Gabriel. Thank you.
Yep. So once again, I'd like to welcome us to this session and hoping that we're going to leave here in good time to pave way for the AGM. So we solicit everybody's cooperation and we ask that you listen with rapt attention. Though we still need a bigger house, so please call your friends, call them on phone, let them come. We don't intend to gloss over anybody. We don't intend to overlook anyone. And we don't intend to disqualify anybody. We want full participation. Everyone will participate. And we are expected to adhere to the rules guiding this competition. The presenters for the abstract should sit on the first row on this side of the hall, on these red seats, while the presenters for the hospital, inter-hospital competition will be on this side of the hall. The first side will be by the, will occupy the tertiary hospitals, while to the extreme, the state secondary facilities will sit there. Having said that, ladies and gentlemen, I want to hand over to the assessors for the poster presentation, that's the abstract presentation. For the abstract presentation, there are 13 entrants. But on the front row, I'm seeing like less than 13 people. I'm seeing like 8. So if you know you're a presenter of abstract, please sit on the first row. Abstract, sit on the first row. If the seats are not enough to occupy all the 13 people, we will provide the extra seats. So I can see 9 now. For the inter-hospital, I can see only 3. Because I believe that the CPC chairman is not a presenter.
Recording in progress.
Okay. I think the people for the abstract presentation are increasing now. They have increased to 12. No? Margaret. So I'm going to hand over the microphone to the lead assessor for the abstract, and we're beginning soon. So he's going to read out the ground norms for that event, which we believe should be as sharp as possible. Thank you very much.
Okay. The chairman permit me to stand on the existing protocol. For abstract presentations, please listen carefully. We have 5 minutes. 5 minutes for each presentation. And we are going to score you on the following. We have done pre-assessment. If you have not done your own pre-assessment, probably we are going to do it immediately we finished. But we have done some pre-assessment and we score you on 40 marks. Then this presentation carries 60 marks. The first criterion we are looking for, the quality, the originality, the creativity, theoretical and clinical significance of your research work, and the uniqueness of research work and timeliness carry 20 marks. The second criterion is organizations of your work, the objectives of your work, the goal of your work, the method and the result, how you organize there in that flow. We are going to score you 10 marks. The third criterion is your delivery, the overall presentations, your oral expression, audible are you, the material and easy flow, free of marks and smuggles. The fourth criterion is your procedures, matching your objectives, how you are really, your method is really addressing or achieving your objectives. We are going to also score you 10 marks. Knowledge of the topic and material, your style, the language appropriate to your research work. We are going to score you 10 marks. That is a total of 60 marks. So go to substance we have mentioned now, so that 40 pre-assessment and 60 presentation makes 100 marks. And on that basis, we are going to score you. I wish you best of luck. The first batch of these presentations, I will call Dr. Daraka to read them out. Thank you.
The chairman and the house, good morning. The first batch of the oral presentation, I have a list of 3 people. The first one is Dr. Modupe. She is presenting on pharmaceutical waste management in community pharmacies in Lagos State. Please indicate by raising your hand if you are here. Okay, you are welcome. The second presenter will be Dr. Afsat. She is going to be presenting on knowledge, perception, and practices of pharmaceutical waste disposal amongst public in Lagos State. Is she here? Okay, you're welcome, ma. The third presenter will be pharmacist Esho Ronke. She is going to be presenting on medicine information and its impact on attitude of outpatients in University of Ilorin Teaching Hospital, Kwara State. Pharmacist Ronke, you're welcome. So, are we starting? Is the ITT ready so that we can start with the first batch? Okay, while we wait for the ICT, I think we can mention the number 4 and 5 to join them. Number 4, the fourth presenter is going to be Pharmacist Ojo Samuel. Pharmacist Ojo Samuel is presenting on legal aspects of drug information practices. Then the Pharmacist Ojo Samuel, is he here? Okay, yeah, number 4. Then the fifth presenter is Pharmacist Joshua Iromosele. He is presenting on incidence of infection and antimicrobial resistance of bacterial isolates from born woods in a tertiary hospital in Nigeria. Is Pharmacist Joshua here? Okay, he has stepped out. He's number 5. So these are the first batch of 5 presenters. Okay. While we wait on the ICT, I think the first 5 should be ready, and we'll have the presentation shortly. Thank you.
Yeah, thank you very much. Where's Pharmacist Akelekuno? IT, please, can you be of assistance to us? Darika. Hello, Pharmacist Steve.
Hello, the chairman, sir. The ICT are ready and it's on display. I want to call on Dr. Modukwe. Are you on stage? Okay. You are presenting on pharmaceutical waste management in community pharmacies in Lagos State. This information is key to all the other presenters. You are strictly going to present for only 5 minutes. At the third minute, we will indicate to you that you have 2 minutes to round up. When it is 5 minutes, we will come and collect the mic so that we respect the 5 minutes timing. Thank you.
Thank you. Good morning, all. All protocols duly observed. I'm going to be presenting on pharmaceutical waste management in community pharmacies. in Lagos State, Nigeria. This was the study that was sponsored by AHAPN Lagos State. Okay. An average community pharmacy in Lagos State, we found out stocks up to 2,000, between 2,000 and 4,000 drug items, and that they generate a lot of waste, which are expired, damaged, unwanted medicines, and most of these end up in the drinking water and the water systems generally. And we found out that limited knowledge on pharmaceutical waste management and poor compliance with the national guideline that is already laid down for medication disposal has been reported by some authors. So based on that, we noticed that there is there are a lot of poor management when it comes to managing this waste that comes because of the way community pharmacy are placed and the regulations that goes around it. Limited studies of pharmaceutical waste management practice among community pharmacy in Lagos State was the one that sets the tone for this study. The general objective was to assess the pharmaceutical waste management knowledge and practice among community pharmacies in Lagos State and to compare them with the NAFDAC guideline on disposal of expired or unused medicine with a view to ensuring proper management of pharmaceutical waste in Lagos State, Nigeria, because we all know that we have quite a lot of pharmacies in Lagos State. Okay, as part of our method, we used a cross-sectional study and
Hello, audience. Are you seeing anything from the projections here? Huh? What about those of you over there? Huh? Are we good to go? Or is still putting? We're not even seeing on the high table. So let's give... Okay, I think we are good to go.
Okay. So it was a cross-sectional study that was used, and because the study started about the COVID, at the tick of the COVID, so we used Google Forms using the social media, And eventually, we also had to use manual survey forms where we got notes from community pharmacies that attended conferences, and even some when they came around to the PCN for their registration. Data analysis was done using the XP33 version. Okay. As part of our results, we eventually used 211 community pharmacies, and 43.6% were found to be within the range of 20. 43.6% of them were in the age range of 25 to 34, and 57.3% were male. 52.1% had less than 10 years post qualification, and majority of them were found to be unaware of pharmaceutical waste management, even as far back as their undergraduate days. And about 48.3% were not aware of periodic requests for pharmaceutical waste by ACPN, because ACPN had a group that they were using for taking the pharmaceutical waste. A majority of them stored the waste inside their pharmacy. A good number of ACP reported regular pharmaceutical waste disposal monthly, up to 32.7%, and quarterly. Majority of them, 44.4%, personally disposed their waste, while only 10% and 36.1% disposed through professional association and regulatory agency. Out of those that personally disposed this waste, some of them disposed by burning, as low as 17.3% though, while some returned to manufacturers, and some use general municipal waste or open flowing gutters, which end up in most of the water systems around, and about 32.3% use the private waste collectors. Also, we can also see it's using these bar charts, what we're just because this was why we get about 162 of the 211 were aware of pharmaceutical waste management, while for the ACP, for the ones that are aware of the ACPN request, we found out that that's what they were going to do. Then concerning the pharmaceutical waste disposal medium that they were using, a large percentage of them were disposing on their own, while the regulatory agencies came second, about 36.1%. Also, the methods used, the burning was as high as 43, while the people that use the general municipal waste, that's the Loma waste in Lagos, were about 76 of the 213.
Your
The
time.
one for septic tank and soak waste.
Just round up.
Because that was
We've
that
given you
day.
3 minutes.
Okay, so the challenges that we found out was that there were regular
Go to
collection by
conclusion, please.
responsible body. The storage space was also an issue for them. In conclusion, study shows the high level of awareness of pharmaceutical waste management, though the measures are, we found out that measures are needed to improve compliance to standard practice in order to ensure proper waste. Our recommendation is that ACPN should work with NAFDAC to ensure regular collection and disposal of pharmaceutical waste, and that government should bear the total cost of disposal, and ACPN should improve awareness on pharmaceutical waste, while manufacturers and importers should assist the community pharmacy, and provision should be made for standard segregation of waste space.
Thank you very much. Thank you.
Thank you.
As a way of reminder, once the timekeeper gives you 2 minutes notice, if you want your presentation to be properly assessed, it should be within the 5 minutes. If you are outside your timeline, your scoring will not be taken for whatever you have presented. We want to be that strict because to respect the time. So thank you very much for that presentation. The next presenter is Dr. Absat. She is going to present on knowledge, perception, and practices of pharmaceutical waste disposal amongst public in Lagos State. You have 5 minutes, ma'am.
If I go, I will be sitting outside. That's why I don't go to bank again.
Now, I'll just
Hello?
check
Good morning. Please, I want to see or for him or any of them. That packaging, I should hold on.
You can start.
Good morning, colleagues. This presentation is on behalf of AHAPN, Lagos State, and the topic is knowledge, perception, and practice of pharmaceutical waste disposal among the public. As a way of background, as a way of introduction, we know that most consumers have a lot of medication after completing their regimen, either because of non-adherence or we have some that are unused and kept. Sometimes, due to adverse drug reactions, you have drugs being left as left unused with the consumer. And there's already increased availability of pharmaceuticals have made it that we have high level of this discharge into the environment. We also have studies that have shown improper disposal of unused, expires or leftover medicine. And these are proven to be it has negative effect on the environment, especially on animals and humans. That is by way of introduction. Presence of these chemicals have been very having negative effect on the environment, as I said earlier. We have pharmaceuticals such as beta blockers, anti-inflammatories, and others. In Nigeria, the National Environmental Standard and Regulation Enforcement Agency regulates waste management, including pharmaceutical waste. And they have said that in a presentation in 2017, they focused on pharmaceutical waste, and it concluded that agencies that should be in charge of that generate this waste should also be in charge of their disposal. So by way of our aims and objective is that these studies aim to look at the disposal of pharmaceutical waste system by assessing the status of the pharmaceutical waste among the public in Lagos State. Specific objectives are to look at the level of knowledge and awareness of these residents in Lagos State, to understand their perception on proper and improper ways of pharmaceutical waste handling, and to assess the practice of the Lagos State residents in disposal of their unused medicines. The method and data collection, we used a descriptive cross-sectional question-based study that was done among the Lagos State residents between April and May 2001. And those that are eligible for this study were 18 years and above. The questionnaire was electronic and it was made available online. Due to the COVID pandemic, we couldn't do physical one-on-one. So the results of this discussion, of this abstract, show that we have 65.5% of the females and 38.8 males participated in this study. 250, that is 46%, were presently on one or more medication. We tried to find out how many medication an individual is on. Then the respondents were over 51% that checked the expiry of products before buying. And about 20.9% of those population were male. Almost out of the respondents knew about pharmaceutical waste. That is 46, about 50%. Many participants have not received advice from the pharmaceutical waste from healthcare workers. So we also look at that and found that result. Then on the knowledge, we have responded at the fair knowledge, about 43.8% had good knowledge of pharmaceutical waste disposal. On perception, using unexpired or expired medication, majority of them had that perception that what they know about the information, that is about 93.6%. About 88.9% have the strategy. They know about the strategy
the perception on the strategy of unused, leftover, or expired medication. These studies also show that 80.3% kept unused leftover medicine at home because they felt better. Then the 39.9% also felt that this ailment has gone, so they should keep the leftover at home. Some of them did this due to the adverse drug reaction they had on used medicine. This presentation, this bar chart is also showing some of the findings of this presentation. So in conclusion, what we have is that a lot of them have the knowledge of pharmaceutical waste. They have a good perception of it, but the policy makers need to look at this, and we recommend a kind of awareness and then take back program that the public should be able to have when they have unused or leftover medicine. They should be able to return it to the source. Thank you very much.
Thank you. The next presenter is pharmacist Esho Ronke. She is presenting on medicine information and its impact on attitude of outpatients in University of Ilorin Teaching Hospital, Kwara State. Please, let's respect the 5 minutes timing so that you can get your due assessment. She's on stage. Okay, Daima, are you ready? You can start.
Good morning, pharmacists, all protocol. This morning I'll be talking on medicine information and its impact on outpatient University of Ilorin Teaching Hospital, Kwara State. My name is Ronke Esho. As way of introduction, health education and higher patient satisfaction has been recognized as a key to promoting better outcomes of healthcare. And we have discovered that utilization of many other services in the hospital is dependent on what the patient experiences in the outpatient department. So as a result, I decided to carry out this survey to see what actually delays or makes patients to come to the pharmacy with anger in their heart because of long waiting time at the outpatient department. So this survey was carried out in some areas whereby the health information were kept, pamphlets and other health papers were kept in the waiting room. But it was discovered that even though patients look at those pamphlets and write-ups, but majority of them couldn't really understand what were written there or the language it was written. So I decided to carry out this research to see the efficacy of health education classes conducted in the waiting room prior to a health or to a patient's appointment with a health provider, and also to describe the impact of patient counseling practices from patient waiting room to follow-up time. A cross-sectional institutional-based survey was used whereby twice a week for 5 months in 3 outpatient departments, the waiting room of family medicine, antenatal, and the MOPD. Patients were counseled before leaving the pharmacy department, telephone calls were made for follow-up, and then the outcomes were documented. What were my findings? I discovered that about 48% of the patients, 500 patients were used in the survey. About 48% of them used both prescription and non-prescription medicine together with herbal products and the likes, they discovered that it was not right. About 37% used their prescription drugs wrongly. About 26% improper use of medicine, lack of adherence. About 10.6% use their drugs at wrong intervals, dosing intervals. Why? Because they couldn't really understand the dosing interval. As a result of pharmacy intervention after increased knowledge, it was discovered that there was improved patient satisfaction, which also led to patients being satisfied with the facility they were using. That was 100%. 78.4% increment in patronage at the pharmacy, because many of them were coming not only to buy their drugs, but also to make inquiry about some drugs and some issues they were having with their drugs. Also, there was about 87% increased knowledge of right drug usage. So as a result, it was clear that increase in knowledge enable patients to build trust, be open, become more aware of the risks of drugs misuse, and ask informed questions. The program potentially increased interest in attending the health education classes, because patients, when they come in the morning, they don't just move around. They are all seated waiting, and they welcome me for the program. This study showed that incorporating educational meetings like health talks related to medicine use and having feedback into the design of waiting time can augment patient pharmacist counseling in outpatient settings in the hospital, because we have discovered that many pharmacists actually don't have one-on-one interaction during dispensing of their drugs. In general, patient satisfaction with pharmacist counseling and care was increased invariably. It was increased invariably satisfaction with the hospital. In addition, a variety of health topics, evidence-based evaluation, and interpreter services were key to success, because the program was carried out both in Yoruba and English. Thank you.
Thank you very much. Quite on time. The next presenter is Pharmacist Ojo Samuel. Pharmacist Ojo, are you here? He's presenting on legal aspects of drug information practices. 5 minutes.
A quick announcement, please. State Specialist Hospital, Shogo, you don't have your presentation. State Specialist Hospital, Shogo.
Ready? Okay, timer. Start.
Good morning, members of the high table, distinguished pharmacists, good morning. I'll be making a presentation on the legal aspects of drug information practices. This is an outline, and the legal aspects of pharmacy is one that has evolved with time and is increasingly getting attention from both general practitioners and most especially from drug information specialists. The responsibility of providing drug information is a core part of the pharmacy profession. You know, the community sees us as drug experts, and even at every point on personal referral basis, we are asked drug-related information. And by drug-related information, I'm talking about current, critically examined and relevant data about drugs and drug use in a given patient in a particular situation. Now, the reason why this study had to be done was because we have observed that in recent times, more litigation is coming against pharmacists, both in diaspora and locally. You know, I heard of a situation of a family friend wanting to sue a pharmacist because they did not warn the patient of adverse drug reactions. And so the pharmacy profession is assuming an increased legal responsibility to provide drug information in the daily practice of pharmacists supervised patients' care. And so it is imperative that every pharmacist, irrespective of our specialization, have a knowledge of the legal aspects of pharmacy. So the objective was to summarize the legal aspects of the provision of drug information, to highlight the impact of legal liability on the pharmacy profession in the area of provision of drug information, and also to emphasize the importance and need of drug information providers to have knowledge in this area. So this presentation is a condensed compilation of what pharmacists need to know regarding this subject. So a literature review was done using internet-based search engines like Google Scholar, PubMed, and Access Pharmacy databases. The legal aspects and recommendations were made on how pharmacists can apply this knowledge in the provision of drug information in Nigeria, and this was compiled. Now, these are our findings. Today, pharmacists providing drug information, be they generalists or DI specialists, are more likely to be held to the same standards as physicians when determining the standard of care. The pharmacist's duty to warn of foreseeable complications of drug therapy is becoming a recognized part of the expanded legal responsibility of pharmacists. Where the patient is at higher risk than the general population, the courts have uniformly found liability. Every pharmacist must understand risk assessment and risk management, because for you to provide an information that can be used by the patient, you need to have details about this patient. So published studies for drug information centers have reported that 41% to 83% of requested information is patient-specific or judgmental in nature. Recent cases against pharmacists have held that pharmacists who gain information about the unique susceptibility of a patient are liable for failure to warn of the risk. So, for example, you might have an electronic database that gives you access to that patient's records, and this puts you in a greater case of liability. And the future of pharmacists as drug information providers clearly lies in their ability to provide consultative drug information services. Currently, most litigations concerning pharmacists involve negligence. In legal terms, we call that tort liability. And drug information providers can protect themselves against liability through adequate documentation, using disclaimers or exculpatory clauses. And currently, most of the drug information being obtained by practitioners and drug users is from the internet and electronic sources. And we were surprised to find that over 20%, 25% of the content on the internet are actually health-related information. And so we pharmacists must understand this. Conclusion: an understanding of the legal aspects of drug information can help practitioners in day-to-day practice, as well as provide some possible ways to protect himself or herself in the legal system. Thus, 21st century pharmacists must be aware of the possible ways legal liability can be incurred. We have a few recommendations, and the summary of it is that every pharmacist must exercise due care in providing pharmaceutical care, because if we are not careful, it's possible that a patient might easily bring a litigation. And most especially, it was also observed that many cases of litigation occurred because the patients were not happy with their pharmacist. That means, in simple terms, they just did not like the pharmacist. And so to prevent litigation in most cases, it is very important to build a right relationship with your patients. Thank you.
Thank you. Thank you very much. The next presenter is pharmacist Victoria Onalo. Is she in the house? Okay. The presentation is on patients' perception on the role of clinical pharmacists at University of Abuja Teaching Hospital, Bagolada. Okay, are you ready? Time, are you ready? Your time starts now.
Good morning, Mr. Chairman, members of High Table, my distinguished colleagues. I'm here, Victoria Onalo, to present on patient perception on the role of clinical pharmacists from University of Abuja Teaching Hospital. This is my introduction. The outline of my work, introduction, you should understand that clinical pharmacists are involved from the traditional way in which we practice. Before we practice dispensing, manufacturing, but now we have moved to patient focus. It is expected that every pharmacist in the hospital is expected to be a clinical pharmacist. We are not supposed to be involved in only drug dispensing. We are supposed to be involved in pharmaceutical care. What is this pharmaceutical care? Pharmaceutical care is all about what? Responsible provision of drug therapy to give a good outcome, to improve patients' life and reduce patient stay in the hospital, reduce adverse drug reaction, reduce drug interaction. As a clinical pharmacist, we're supposed to be able to prevent management, assess every drug adverse drug reaction. We're supposed to prevent and manage drug interaction, document. We're supposed to be involved in ward round. We're supposed to be involved in medication therapy management. We're supposed to be involved in drug therapy monitoring, ensuring cost effectiveness. This, you can see an example of this. Wrong perception, poor attitudes, inadequate pharmaceutical care. What does it lead? It leads to drug therapy problem. Does this, our research question, does this demographic influence perception on role of clinical pharmacists among patient UNH Gwagwalada? Does this social demographic influence perception on the role of clinical pharmacists among UNH Gwagwalada? Aim of this study, the aim of this study is to evaluate the general perception of patients on the role of clinical pharmacists in University of Abuja Teaching Hospital. These are my objectives: to collect patient demographic data, to assess patient knowledge of pharmacy profession, to manage patient perception towards management of medication therapy, to ascertain patient perception towards collaboration with other health practitioners, to evaluate relationship between patient and demographic and perception on pharmacist role. My methods: a cross-sectional survey was done within 4 weeks. We carried out a pilot study within 2 weeks, and ethical approval was obtained for this study. The study was just 4 weeks. We used outpatient, general outpatients to carry out our study. In the general outpatient, we have almost 840, and the sample size was determined using Thyroemus simplified formula. A convenient sampling method was done using questionnaire. From the results, we can see that those people that are highly educated, self-employed, have more perception. Those people that are highly educated have more perception. The active age patients have more perception on the knowledge of pharmacists, while the married people have more perception on the knowledge of pharmacists. Now, from the result also, more male questionnaire was administered to more male, but we discovered that the female have more perception. This is as a result of female have the ability, the ability to visit the hospital more than male. Knowledge of pharmacy was high compared to interprofessional collaboration. They have the knowledge too. Medication therapy was not, we have more negative perception because most patients believe that pharmacy is not supposed to be involved in their medication therapy. Also, most patients believe that they want the doctor to administer their drug within the dispensary room, maybe because as a result of some doctors involved in doing that. So they see it's very easy for them. The discussion, we can see that, as we have earlier said, most patients, we have more females that have a high perception of knowledge of pharmacy than male. We have more married people, as I've earlier said, based on the fact that married women visit hospital more. In conclusion, patients of University of Abuja Teaching Hospital have good knowledge of pharmacy profession, excellent perception towards collaboration between pharmacists and other health professionals. Women and married people, there is still large room for improvements, especially therapeutic management. So an increased level of knowledge needs to be passed. We can do that through pharmaceutical care, through involvement in pharmaceutical care. Thank you.
Your time is up. Thank you. Thank you very much. The next presentation is going to be taken via video. Is the ICT ready? While we arrange that, we can take the next physical one. Dr. Ajao, you can come onto the podium. His presentation is on management approaches to urological failure among adult outpatients receiving antiretroviral therapy in a tertiary healthcare facility. If it's ready, then Dr. Ajao, you should hold it for us. Is it ready?
Okay.
No, let him join in 10
Bayelsa.
minutes. We'll get
Okay,
to
thank you.
join. You present.
I think he's one that wants.
Go ahead.
And I need to represent in Agua. Agua few win this time, sure. Let's see. But Ilorin, Kwara win last year. University of Ilorin Teaching Hospital.
Okay, I think let the other people be on the standby while we are ready for him. After Dr. Ajao, we'll take the virtual presentation by pharmacist Inkem Jika Williams. Then the next one is pharmacist Joshua Romosele, who is going to be number 8. Number 9 will be pharmacist Olulawal. Number 10 is pharmacist Babadan Juma. And number 11 is pharmacist Obideke Ruth. Number 12 is pharmacist Peter Agada. And the last but not the least is number 13. Yeah? Yes, the visual one is number 6. It's the one after Dr. Ajao. So please be on standby, and it's strictly 5 minutes.
Yes. I think we're experiencing some slight technical hitches. And I want to use the opportunity to do a few recognitions of the persons in the house. Seated with us here is Group Captain Ike Ojeme. And I want to believe that those who are sitting around him, they are members of his entourage. He has also extended warm greetings from his commanding officer, Group Captain Babalola, who was with us at Ibadan. I'd like to recognize the presence of the CPC chairman, who also doubles as the secretary of the Committee of Heads of Pharmacy in Federal Health Institutions, Dr. Mrs. Caroline Luatimile, PC Farm, FPSN. I'd like to recognize the presence of all of you who are here. I may not be able to mention your names directly, but I know I can see Tina Aliedo from Abuja. I don't know whether pharmacist, the former HOD of OAUTH, if he's here, Moron KG, please, can you be upstanding for recognition, sir? I can see my colleague from Jos University Teaching Hospital, Pharmacist Buanugo Johnson, Joseph Sunday. Please, can you stand up for recognition? I can see the ELECO chairman, Pharmaceutical from Delta State. Please, can you wave at us? Wave your hand and shout hallelujah. I want to thank you for the, yes, I can see the AHAP chairman, Pharmacist Malagi from Mina. Where are the elder statesmen here? While we're still sorting out, I want to say that our conferences are getting richer, bigger, and better. My brother is here, pensioner, NMPC pensioner. Tanku Ayuba, please take a bow, sir. Huh? For the inter-hospital competition, the following hospitals are physically present here, and they are going to make presentations. Number one is Ilorin University Teaching Hospital. Please indicate, where is the presenter? Just raise up your hand. Okay, but I'm sure it's here. Jos University Teaching Hospital. I can see you, thank you. Federal Medical Center, Yenagua. University of Abuja Teaching Hospital, Gwagwalada. General Hospital, Meitama. University of Uyo Teaching Hospital. Uyo Teaching Hospital. Where is Regina? Okay, maybe she's on her way. General Hospital, Gwarimpa. Anybody from Gwarimpa? Where is the presenter? Okay. NAFDAC. Where is the NAFDAC person who is making the presentation? We have FCT Health Insurance. That is great. Thank you. Adeoyo Maternity Teaching Hospital. Thank you. And State Specialist Hospital, Oshogbo. State Hospital, Oshogbo. All right, thank you. I think we are good to go.
Dr. Ajao, please. Time, are you ready? Carry on. Second. second mic. Okay, the mic is there.
Good morning, my chairman, the panel of assessors. Please permit me to stand on existing protocols. I'm Dr. Olumuyiwa Ajao, an Assistant Director of Pharmaceutical Services at the Obafemi Awolowo University Teaching Hospital, Ile-Ife. I'm making a presentation on management approaches to virological failure among adult patients receiving antiretroviral therapy in a tertiary healthcare facility. Now, the first slide is a summary, is an outline of the work, and I'll quickly go through the main work. As an introduction, there's no gainsaying that human immunodeficiency virus has affected everyone. We are either affected or infected. Now, the Joint United Nations program on HIV/AIDS, according to their 2017 report, said that 36.7 million people all over the world were living with HIV/AIDS. And incidentally, the figure has increased by 2020. And in the same 2017, 1 million people died from AIDS-related illnesses, and about 1.8 million were new HIV-infected people. Now, also in 2013, WHO updated its guidelines to promote earlier treatment initiation and enhanced patient monitoring. Now, the rapid scale-up in the global HIV antiretrovirals in remote resource-controlled settings, including Nigeria, has led to massive enrollment of patients, especially in the past decade. So many patients are enrolled in treatment and care settings. But interestingly, despite the improved access to antiretrovirals, incidences of virological failure among patients on first-line antiretrovirals in treatment centers has led to switching from first-line antiretrovirals to second-line antiretrovirals. Now, recent studies have outlined incidences and factors responsible for virological failure in resource-controlled settings, but there have been limited studies that have outlined strategies that can be used to effectively manage virological failure. Hence, this study seeks to bridge the gap between the existing literature. Now, the study objective is to establish the incidence of virological failure, and to investigate factors responsible for virological failure, and to find out intervention strategies adopted in the management of virological failure. Now, the subject and research protocol, we have the design, a retrospective design with a retrospective descriptive research design. And we have two treatment groups, the tenofovir lamivudine efavirenz group and the zidovudine lamivudine nevirapine group. The study period was from January 2015 to December 2018. Now we had exclusion and inclusion criteria. We studied subjects above 19 years old who are not pregnant and who are on the treatment groups. So data were collected retrospectively by extracting data from patient case files. Now, the analytical tools used were frequency and percentage distribution, t-tests, and regression analysis. Now, the findings, figure 1, incidence of virological failure among the treatment groups. According to that figure, you can see that the percentages of unsuppressed in the treatment, both treatment groups were significant. 17.7 in the tenofovir lamivudine efavirenz group and 6.2 in the zidovudine lamivudine efavirenz group. Figure 2 also, according to the findings, factors responsible for virological failure among the treatment groups. You could see that recording incidences of skipping of doses and going on drug holidays were significant factors responsible for virological failure. Now, figure 3, according to my findings, average viral load counts for the treatment groups at 3 months and at 6 months dropped significantly. So there was a significant drop at 6 months for both groups. Now, in conclusion, intervention strategies adopted in the virological failure, in the treatment of management of virological failure among the treatment groups, you can see that about 10 intervention strategies were highlighted. And in that 10, 6 strategies cut across board. Now, conclusion, the study established the significant incidence of virological failure and also identified 2 factors significantly influencing the incidence of virological failure. And the study also identified 10 intervention strategies in management of virological failure.
Up.
Thank you.
Thank you. Thank you, Dr. Ajao. We will take the video presentation by pharmacist Nkem Jika Williams. His time starts now. Hold it, please. Hold it. How do you do that? Okay, we are still having some technical issues. I think we will take the next physical presentation. The next person is pharmacist number 8 is Joshua Remosele. Is his own cued? He's presenting on incidence of infection and antimicrobial resistance of bacterial isolates. Is it ready? Sorry. The next person should be ready, which is number 9. Pharmacist Olu Lawal is going to be presenting on assessment of attitude of hospital pharmacists in Ogun State. Yes, that's it. Josh Kwara. No, it's the technical issues that we had. The virtual presenter had it match with his presentation. The virtual we wanted to do. So that's why I shut down that one. Presenting. He's ready. Timer, are you ready? Start. He's not here.
Good morning, members of the high table and everyone here present. Please permit me to stand on the existing protocol in view of time constraints.
We can't hear you. Maybe you need to remove your...
My name is Pharmacist Joshua Iromosele, and I'm here to present on the incidence of infection and antimicrobial resistance of bacterial isolates from burn wounds in a tertiary hospital in Nigeria. This is the outline that will be guiding this presentation. Globally, 61% of deaths occur in born patients due to infection of their bone wounds. And this is the most common complication in born patients. Interestingly, antibiotic-resistant microorganisms are increasingly implicated in this statistic and causes delayed wound healing, further complications, and higher risk for poor prognosis and death. The overall purpose of carrying out this kind of research is to be able to contribute data that drives forward rational prescribing of antibiotics. The study investigated the incidence of bone wound infection and then antimicrobial resistance in isolates from the bones wound. Its objectives were to determine the incidence of bone wound infection in the facility for the study period, obtain and interpret and document microscopic culture and sensitivity data, as well as investigate antimicrobial resistance in the isolates encountered during the study period. This work was carried out in the Bones Intensive Care Unit of the National Trauma Center in Abuja and involved patients who were admitted from January to July of 2018 or to June of 2018 with various bone injuries. Pregnant women, newborns, nursing mothers, infants, and those whose immune system is depressed by drug use or disease state were excluded from the study. From January 2018 to June 2018, a total of 36 patients were admitted and they were all eligible. The isolates were identified using preliminary ground staining, colony morphology, and then this diffusion method was used to determine the antibacterial sensitivity of the isolates. The data was collated and presented in frequency tables and graphs using Microsoft Excel, and then chi-square test was used to determine associations, but for cells with a count less than 5, Fisher's exact test of probability was used. Graph Prism software used to do the inferential statistics. What were the findings of the work? The number of children under 5 admitted were significantly higher at 77.8 compared to children between 5 and 10, and their bones were caused by mostly hot water scald bones. Positive cultures implicating 5 pathogens, namely Pseudomonas, Staphylococcus, Klebsiella, Acinetobacter, and Proteus, were identified in 53.6% of the admitted patients. The first table just buttresses what I have just said, but I want us to look at table 2. Table 2 is talking about mixed infections. When we take swabs from the wounds of these patients, we are hoping to meet one organism, but sometimes we meet more than one. And if multi-drug resistant organisms are involved, it further complicates the situation. This is a graphical presentation illustrating that 74% of the organisms isolated were multi-drug resistant in red. This table illustrates that the antibiotics that were given, for example, for Klebsiella pneumoniae, 100% was resistant to ceftriaxone. I want us to also notice that for meropenem, also 100% of Klebsiella pneumoniae was resistant to meropenem. Positive cultures were observed in 53.6% of patients. But to make sense of this, we have to do a comparison in other places. So in Iran, for example, we have lower incidences of 38.5, but up to 80% has been observed in certain studies, like by Fosson et al. In 2017 in Ghana. This study also showed that 74% of the isolates were multi-drug resistant, and this is consistent with trends in other findings. All the antibiotics were found to be ineffective at one point to the isolates, except for colistin, which was observed to be effective in all instances of testing. This has grave implications on various aspects of care, including increasing costs and increased risk for side effects and medication errors, because some of these antibiotics, colistin, as a case point, is in international units, and there are errors. Not to talk of the side effects of nephrotoxicity and neurotoxicity. This work is a work that I conducted in 2019 that talks about nephrotoxicity of colistin-induced work. The abstract is available on PubMed, but if you are doing a research on this work, please, I'll gladly give you the full work. Pharmacists' participation and intervention has reduced unnecessary use of antibiotics, prophylactic use, and prolonged duration of antibiotic regimens, which contributes to the development of multi-drug resistant bacteria. This underscores the importance of clinical pharmacists in optimizing drug therapy and bringing the weight of their knowledge and experience to bear in addressing these problems. I will conclude with this ICT aspect. Active monitoring involving the use of technology in tracking and documenting transmission of antimicrobial resistance data is a major recommendation of this work. And I'm pleased to inform us here that the data collection tool used in this work is currently being used to design the database for real-time active monitoring of antimicrobial resistance in my facility. I conclude by saying that 53.6% of patients were infected in the course of their stay in the hospital, and 74% of those infections were caused by multi-drug resistant bacteria. Thank you for listening. These are my references. Thank you. Thank you.
Thank you. Is the video ready? We want to try the video, I think, so that we give the contestants a fair.
Good evening, my highly esteemed senior colleagues and distinguished colleagues. I am Nkemjika Williams Okoji, a clinical pharmacist, and I'm here to do a presentation on diabetes. Good evening, my highly esteemed senior colleagues and distinguished colleagues. I am Nkemjika Williams Okoji, a clinical pharmacist, and I'm here to do a presentation on diabetic self-management skills and anti-diabetic drug adherence among diabetics outpatients in a tertiary hospital background. Diabetes is a chronic condition that is characterized by hyperglycemia and has affected well over 500 million people globally. It's important to take note that African region has the worst outlook for diabetics. Example, 60% of the people living with diabetes are not diagnosed, meaning that these people will present at the point of diagnosis with 1 or 2 diabetic complications. Little wonder over 75% deaths due to diabetes occur in people under the age of 60 years. This is worrisome in our region. Therefore, this study assessed the patient adherence to diabetic self-management skills and their medication regimen. The method in this study involved both phase 1 and phase 2. The phase 1 involved the retrospective review of case notes of type 2 diabetic patients that are attending. The table 1 shows us that over 81.9% of these patients were not prescribed the fixed dose combination. This pattern of prescription will increase their pill burden, which eventually will increase the chances of non.
As the only thing that is constant in life is change, no profession has manifested this as much as the pharmacy profession. From the days of the apothecaries down to pharmacy becoming a diploma something and going to degree, BSc and BPharm, which was product oriented. Then we moved on to clinical pharmacy, which saw pharmacists moving from the 4 walls of the pharmacy down to the wards to take on more patient-oriented roles. This gave birth to the PharmD degree program. So this study is looking at the conversion program for pharmacists that already had PharmD, that already have BPharm degree. Objectives. The objective of the study was to assess the attitude of hospital pharmacists in Osun State to PharmD conversion program, to evaluate factors that may encourage participation in the conversion program, and to identify perceived barriers towards participation in the conversion program. The study design was cross-sectional, ethical clearance was duly obtained, population use was hospital pharmacists, with the inclusion criteria being working in Osun State, exclusion were those already on the program. Data analysis were used was frequencies and simple percentages, and the sampling technique was convenience. I present the results. The response rate was 87 out of 105 questionnaires distributed, which was 82.8%. From the respondents, there are more males than females, 60 to 40. The highest qualification was BPharm with 78% having BPharm as the highest qualification, 13% had fellowship,
and 8% had masters. We asked them about their willingness to undergo the conversion program. 87% of the pharmacists were willing, while 13% were not willing. The results showed that the reasons for conversion, which they cited, was to improve their clinical knowledge, to be able to serve the patients better, and to improve on clinical skills. Other reasons cited was proximity to a faculty, which should be encouraging, implementation of clinical pharmacy services in the various hospitals where they are working, release by employer, then sponsorship by employer for some will make them to be encouraged to undergo the program. Now, we looked at barriers towards enrolling. Some cited the cost of the program. This was the highest with 75.9%. Then distance from a faculty to time to study for such program. Mode of delivery, others believe that online, that's 62%, believe that if online learning could be employed, it would be better. In the discussion, most Nigerian pharmacists responded had positive attitude to PharmD conversion and pharmaceutical care. Involvement in practice is the main reason behind the desired conversion, while support from employers and recognition of the certificate will enhance their participation. In conclusion, hospital pharmacists in Osun State are willing to undergo the PharmD conversion program. They are likely to be motivated by proximity to a faculty of pharmacy, implementation of clinical pharmacy services, and additional benefits like salary scale placement. Perceived barriers are cost and distance from faculty of pharmacy. A flexible conversion program will aid it. Thank you.
Thank you very much for keeping to our time. The next presentation is by pharmacist Babadan Juma. The title of his presentation is Assessing Pharmacists' Attitude Towards Pharmaceutical Care in Nasarawa State. The next presenter should be ready. Pharmacist Obideke Root, Medication Error Amongst Pediatric Population in FMC Yenegua, Bayelsa State. Followed by Pharmacist Peter Agada, Reaching Out to Hard-to-Reach Population in Nigeria with HIV self-test kits in the Southern Nigeria experience. Are you ready?
Yep.
Timekeeper, are you ready? Okay, start.
Good morning, the high table. My distinguished colleagues. My name is Dr. Danjuma Oyinaka Baba. I'm the Director of Essential Medicines and Logistics, Nasarawa State Primary Healthcare Development Agency, Lafia, Nasarawa State. My presentation is centered on assessing pharmacists' attitude towards pharmaceutical care in Nasarawa State. And I'm the lead investigator, that is the principal investigator, with my colleagues there that have been cited. You could see that when I was just recently posted to the agency to coordinate the essential medicines and logistics. But this work was done when I was serving as an assistant director, Dalhatu Arab Specialist Hospital, Lafia. The background of the study is actually assessing the attitude of pharmacists towards pharmaceutical care. We will all understand that globally, the growing trend now is the approach towards applying pharmaceutical care in providing services for patients. And so that informed the conceptual framework of this work. The objective was to actually assess the attitude of pharmacists towards pharmaceutical care in Nasarawa State. I limit myself within the context of the work I submitted. So that is why this work came out like this. And so the method was a structured one, a self-administered questionnaire. actually been adopted from previous work done in this line, which was on pharmaceutical care attitude survey, that tool that I used to apply, which is in form of have various components of the structures of the questionnaire. So the methodology captures all the framework that has been identified, and the analysis aspect of it was actually a descriptive statistics that was used, using the SPSS version 20 with a probability rate of less than 0.5%, 0.5. In the result, we will find out that most pharmacists actually have a very strong attitude towards pharmaceutical care. Strong attitude, which was around 80%. And we have the average age of respondents to be 33 years. Majority of the respondents agree that it will be those pharmacists that have clinical background should be able to adopt or use the method of use the approach of pharmaceutical care in delivering pharmaceutical services to the patients. And most of the respondents, about 51%, actually indicated providing pharmaceutical care takes too much time. So you could see that for the fact that there is a strong attitude, using this response rate alone will further dilute whether they actually understand the concept of pharmaceutical care or not. So, conclusively, in spite of favorable attitude towards pharmaceutical care, you will agree with me that because of the wide gap in knowledge, there is wide gap in knowledge, and the level of knowledge and skills will not match. Because you can understand that there are some questions, though the questions are subjective in nature, it's easier for someone to say yes or no, or strongly agree or not agree. But you can agree that despite the favorable attitudinal, positive attitude towards pharmaceutical care, but having it at the back of our minds that it takes too much time for you to deliver or provide pharmaceutical care, that one will dilute the whole. So we all accepted that pharmaceutical care is the way to go. And providing pharmaceutical care, because we have, if you look at the WHO health system building blocks, where our effort should be focused on is on service delivery, not on supplies. Because one of the building blocks of health systems is provision of essential medicines.
Conclusion.
So, conclusively, it will be worthwhile for pharmacists to have this desire, because that is the only approach. Because that is when you now begin to think of your medication therapy management. That is where you talk of your identification of drug therapy problems. That is where you provide interventions. And all those interventions you are going to provide, you have to create
your
a way
time
of
is up,
documenting
sir.
it. So thank you for
Thank you very much. Yeah. The next presentation is by pharmacist Obideke Ruth. She is presenting, are you here? Okay. Her presentation is on medication error amongst pediatric population in Federal Medical Center in Egwa, Bayelsa State. The next presentation after her should be ready by pharmacist Peter Agada. His title of presentation is Reaching Out to the Hard-to-Reach Population in Nigeria with HIV Self-Test Kits, the Southern Nigeria Experiences. After him will be pharmacist Wahid Adeoye. The title of pharmacist Wahid Adeoye's presentation is Using the queuing model to evaluate and predict optimum outpatient pharmacy dispensing services in Lagos University Teaching Hospital. The next presenter after Pharmacist Wahid is Pharmacist Oluwabusuyumi Abolarin, Patient Satisfaction with Pharmacy Services at Federal Staff Clinic, University of Ilorin Teaching Hospital. The last presenter of our session today will be Pharmacist Kwara Uju. The title of her presentation will be Promethazine Vanishing Cream Formulation for the treatment of allergic reaction. All our presenters should be ready so that we quickly spend the time. Are you ready? Are you ready? Please start.
Good morning, distinguished colleagues.
Okay, hold on, please.
Hello. It looks like the noise level is increasing. Group captain, please, do you have any of your guys here? Please. Hello. Our colleagues in the exhibition area, please, we want your transactions on a mute mood. You should mute yourselves over there. Please, those of you in the exhibition area, mute yourselves. We don't want to use any other thing to mute you for now. If you do not mute yourselves in 1 minute, we will cause you to be muted. Colleagues in the exhibition area, please mute yourselves. The man in green and yellow. Officer in green and yellow, mute yourself. If you do not mute in 1 minute, we will cause you to be muted. Thank you. Please go on.
Good morning, colleagues. My name is Dr. Azate Mwesi. I'll be doing a presentation on medication error among pediatric population in Federal Medical Center, Yenagoa, Bayelsa State. As a way of introduction, medication error is a failure in the treatment process that leads to a potential harm to the patient. This medication error could either be large or small as the case may be. Types of medication error, we have prescribing error, transcribing error, dispensing error, and administration error. Caregiver for patients. Children depend largely on caregivers for their medications to be given. And these medications come in liquid forms, and therefore, this caregiver needs time to actually get the actual dose to give to this patient. Also, the palatability, ease of administration, and quality of these medications needs to be taken into consideration. Justification for this study. A lot of these patients are being exposed to risks emanating from medication error because they are developmental stages, and therefore, they are more prone to medication errors. Majority of this medication comes in dosage forms that are more suitable for adults than children. Also, for you to get an appropriate dose for this medication, the child's weight needs to be taken into consideration. Aims and objectives. The general aim of this research is to evaluate the degree to which these medication errors occur and their implications. Specific objectives include to investigate the origin of these medication errors, to evaluate the common types of medication error, to assess medication error leading to severe exposure to this medication error. I'll call on Pharmacist Obideki to continue with this presentation.
Good morning, colleagues. All protocols duly observed. For this study, a convenient sampling technique was used with a pre-tested validated questionnaire from the period of February to April 2020. It was carried out amongst 89 healthcare professionals, including doctors, nurses, and pharmacists, 215 caregivers, and patients. Appropriate statistics was used using SPSS version 20. For the results, we found out that transcribing, administration, and dispensing errors were most commonly committed by healthcare professionals, where the doctors were the highest, 43.8%, nurses had 8.2%, and pharmacists had 18%. Pediatric patients were most exposed to administrative errors, with overdose of 51.7, which was highly rated, and was followed by inappropriate route of administration, 49.5, and lower or reduced frequency. Antibiotics were mostly implicated for medication errors in children between the age of 1 to 4, which led to diarrhea as an unpleasant outcome of therapy. In conclusion, medication error in Federal Medical Center in Egwa is high. Some practice deficiencies such as overdosing, underdosing were observed amongst healthcare professionals and caregivers respectively. Medication errors were found in the following order: transcribing, administration, and dispensing. The most serious consequences for patients' health were related to overdoses of drugs that were administered via the intravenous route or intramuscular routes. Children between the age of 1 to 4 were mostly at risk of being affected. Thus, special attention and precautions are appropriate when administering drugs to pediatric patients. Recommendation: in drug administrations, the 5 rights of drug administration should strictly be followed: the right drug, the right patient, the right route, and at the right time. Thank you for listening.
Thank you. The next presenter is Pharmacist Pharmacist Peter Agada. Peter Agada, are you here? No. Okay. Reaching out to hard to reach. His paper was assessed and he was queued to.
Hello. Please, where's Pharmacist Peter Agada? Is he in the hall? Peter Agada. All right, call your next person.
Pharmacist Wahid Adewi, using the queuing model to evaluate and predict optimum outpatient pharmacy dispensing services in Lagos University Teaching Hospital.
Good morning, my colleagues. I'm Dr. Adewi Wahid. I'm here before you to speak on the topic using the queuing model to evaluate and predict optimum patient pharmacy dispensing service in LUT. And this is the outline. Queuing theory is an operational research tool which makes use of mathematical models in the study of queuing systems and has several applications, particularly in a patient pharmacy setting. And we know that the indicator for ensuring quality assurance in a patient setting is the waiting time. So a queuing system is a system that has the potential for the formation of queues. And we have a queue when the waiting time is longer than the rate at which service is delivered. So in the system, the setting that I use for this study is the family medicine, GOPD, pharmacy unit, where you have the service mechanism in this unit is a single queue, a single server system. There's no time to discuss all this. So this is the figure, this is the sketch of the pharmacy unit. The pharmacy unit renders service to patients in GOPD, which are fee-paying patients. Then schools in LUT, on returnship, UNILAG students on T-ship, as well as NHIS patients, primary and secondary. And the average number of patients served per day is 55. The floor space is 21.74 square meters. So when you look at the number of patients served in the pharmacy unit, more than 70% are under NHIS and T-ship. So the objective of the study is to simulate the queuing network in the pharmacy unit in order to assess its performance and to develop necessary strategies for optimizing service delivery. So queuing theory is about modeling, building models in the study of a queuing system. So we are going to the methods. Initially, we had ethical approval obtained from a LUT. The method is a prospective analytical observational study done by simple random sampling of patients seeking pharmaceutical care in the pharmacy. And the technique involves using workflow time study analysis. I use a sample size of 122 patients who gave consent to participate in the study, and I had ethical approval obtained from a looted research and ethics committee. I made use of time monitoring chart to measure patient waiting time in the pharmacy. And data were collected for over a period of 4 weeks. The analysis was done using SPSS, and there are formulas for calculating performance indicators. So the waiting time was determined, and the result I got, the mean total patient waiting time is 79.24 minutes, with the process component of 7.9 minutes, and delay component 71.34 minutes. Prescription validation and assessment waiting time took the largest portion of the total waiting time of 30.87 minutes. And counseling time was 1.31 minutes. This indicates that there's little or no patient counseling being done in the unit. When I simulated this into a single queue multi-surface twin system, the optimal service level at the pharmacy unit is achieved with 2 surface points having a minimum total cost of 1,900 naira per hour, in contrast to the existing single server system with a total cost of 3,874 naira. This results in 88% reduction in total patient waiting time and 50% in total cost when compared with the existing system. And this will require 6 pharmacies comprising of 2 interns and 4 pharmacies. So I had graphs and data showing all this. Conclusion: significant reduction in waiting time can be achieved by facilitating service delivery at the prescription validation and assessment point. Existing staff strength cannot cope with service demand for services. There's an urgent need to employ more pharmacists. So queuing theory is thus a vital tool to assess the efficiency of service delivery in our patient pharmacy. What are my recommendations? Introduction of more assessment points, improving the capacity for data entry and prescription fetching, increased staff strength, payment point, lab space to accommodate pharmacy activities and for enhanced workflow. To manage excessive waiting time, waiting area can serve as an avenue for dissemination of drug information and provision of educational materials to patients. Thank you very much for this.
Thank you. Pharmacist Ilorin, patient satisfaction with pharmacy services at Federal Staff Clinic, University of Ilorin Teaching Hospital, Nigeria. The last presenter will be pharmacist Kwara Uju, promethazine vanishing cream formulation for the treatment of allergic reactions.
Okay. Good morning, panel of judges, distinguished colleagues. My name is Busayo Ilorin, and I'll be presenting on patient satisfaction with pharmacy services at Federal Staff Clinic, University of Ilorin Teaching Hospital. This is my outline. By way of introduction, there are several areas of expertise professed around the world, and the need for them keeps increasing with each passing decade. Pharmacy profession is a noble one, and it seeks to meet the adaptable changes of societal expectations. Statement of problem. There's a non-uniform adoption of a new practice model as the opportunities for it emerges. And there's also a non-uniform series of sudden transitional changes in practice, meaning that as there are several changes in the pharmacy profession, different hospitals adopt it at different points in time. Justification of the study. As we all know, any functional system must have an appropriate feedback for it to be very functional and effective. Evaluation of all patient satisfaction on various matters concerning healthcare services provide insight into the drawbacks of the healthcare system, and it helps in refining the system. There's an obvious paucity of data in northwestern Nigeria on patient satisfaction in pharmaceutical care, and thus the need to assess patient satisfaction to understand the quality of pharmaceutical care in Ilorin, Nigeria. The main objectives of this study was to assess the level of satisfaction of patients who have been to the pharmacy unit to access care. Specific objectives include to determine the level of patient satisfaction with pharmacy services, which was divided into structure, that is like the space in the pharmacy, as well as the level of privacy that they had. And then into processes, which means how the pharmacist was able to counsel the patient well and explain to the patient the dosage regimen, frequency, storage condition, and side effects. Also, specific objective was to determine the parameters with the highest and lowest satisfaction to the patients, and to determine the association of patient satisfaction with socio-demographic characteristics. It was an institution-based descriptive cross-sectional study conducted on 130 patients who accessed care at the pharmacy between 1st to 22nd of October 2019. Convenience sampling was used, and a structured interview guide was used, which was pre-tested on 41 patients, and it had a Chromback Alpha score of 0.93. The data collected was entered into and analyzed using SPSS version 25. Results, we had more males in the study, and we had patients in the age range of 30 to 39 being the highest. We had more of government workers, and we also had more of repeat patronage patients. And for the payment status, we had more of insurance, people on NHIS, that is National Health Insurance. There was a positive correlation between the overall mean satisfaction score with the structure as well as with the process. The overall mean score the respondents gave to the satisfaction with pharmacy services was 3.31, which was above average. And the patients were also slightly more satisfied with those that bought drugs by themselves above those that bought on behalf of others. The study also found out that there was a correlation between mean process satisfaction score and overall mean satisfaction, which was higher than that of the structure. This stems from the fact that procedural aspects of pharmacy services are likely to affect the patient's well-being more than the structural process. That means that patients are more satisfied when pharmacists explain to them what their drug is all about, how to use it, than if you have your structures intact in pharmacy, like adequate storage space as well as privacy. In conclusion, the overall mean satisfaction of patients in Ilorin was above average. There was clarity of instructions and courtesy shown by the pharmacist, which contributed positively towards a higher satisfaction score. Cleanliness and appearance of the pharmacy were also important structural aspects to happiness in the study. However, unavailability of prescribed drugs was the factor with the lowest satisfaction score among patients in Ilorin. Our recommendation: efforts should be intensified by hospital management to make prescribed drugs available, and the pharmacy audit unit should be created and incorporated into pharmacy department to ensure that pharmaceutical processes are observed. These are my references. Thank you for listening.
Thank you. Quite within time. The next presenter is pharmacist Kwara Uju. She is presenting on promethazine vanishing cream formulation for the treatment of allergic reaction. Are you ready? Okay, timer. She's ready. Start.
Good morning, professional colleagues. My name is Chukuro Obianuju. I'll be presenting promethazine vanishing cream formulation for the treatment of allergic reactions. Compounding is a traditional method of preparing medications to fit the unique individual need which cannot be met with the commercially available products. Promethazine hydrochloride is a first generation H1 antagonist, an antihistamine, and antiemetic medication with a strong sedative effect. Promethazine vanishing cream is a topical antihistamine which is not available in pharmacies in Nigeria. The aim of the study was focused on the formulation and evaluation of promethazine vanishing cream. The materials used includes white soft paraffin, cetyl alcohol, propyl glycol, polysorbate 80. These materials were weighed and mixed together and heated to a temperature of 50 degrees centigrade. The oily phase was mixed with the aqueous phase before incorporation of promethazine injection. The cream was mixed until a homogeneous cream was formed. The cream was evaluated. The results of the physicochemical evaluation includes the pH of the vanishing cream was within 5.8 to 6.0. The viscosity of the vanishing cream showed 524.40 Pascal per second. The spreadability was satisfactory. The stability study shows that the physicochemical parameters were consistent after 6 months of storage. Promethazine vanishing cream is used for the treatment and control of the following symptoms: allergic symptoms, which include hives and itching skin, motion sickness, nausea and vomiting. In conclusion, compounding and quality control of medicines that are not commercially available remains a reliable means of meeting the specific need of a patient within the hospital and beyond. Thank you.
Wow, thank you very much. Is the old video now ready? Is it ready? Chairman of Scientific, you lead this one. The last one.
Let me show you some. And distinguished colleagues, I am Ntomchika Williams Okoji.
It's my part that they are having issues. They are having issues. Yeah, they are having issues.
Are you hearing us?
Good evening, my highly esteemed senior. Good evening, my highly esteemed.
I just want to spoil my day. I just want to spoil my day. Then go on well. I am spoil my day.
An anti-diabetic drug adherence among diabetics, anti-diabetic patients, and anti-diabetes. Diabetes is a chronic condition that is characterized by hyperglycemia and has affected well over 500 million people globally. It's important to take note that African region has the worst outcome for diabetics. Example, 60% of the people with diabetes are not diagnosed. Meaning that these people will at the point of diabetes. Example, 60% of the people with diabetes at the point of diabetes. Example, one. And their medication regimen.
Hello.
The method.
It looks like
both phase 1 and phase 2.
well, I think we're still having problems with that video presentation. We will step it down, but we will assess it. It will be made available to the assessors so that we can move on to the next round. I think, is that not the last person? Good. You want to hold on. Okay, be fast.
Who are attending this department.
The chairman, distinguished colleagues, please can we appreciate all the presenters?
And distinguished colleagues. I am Ntomchika Williams Okoji.
They have done very well, and we appreciate them, and we expect this thing to continue. We want to go as far as to FIP standard. We have some certain observations which we want to pass across because of next future presentations. We have a total of 14 abstract presentations this morning. 13 were successful. The last one is the video which was not properly arranged. And other observations we noticed from the whole presentation is that most of our people waste a lot of times on introductions and all the rest. They don't go straight to the matter because it's only 5 minutes. I think the FIP is about 7 minutes. So we are watching toward that so that when you go for FIP presentations, we're able to beat the time. And some of us are reading directly, they are reading their slide instead of reading on the slides. Too many wordings, no PowerPoint presentations. We observe them. We also noticed that most of these works were not carried by ethical approval from where they did the work. None of them showcase their ethical approval, and such it cannot be publishable. So you have to go ahead to obtain your ethical approval to be able to do justice or publish the articles. We also want to tell you that some of our colleagues did their presentation of PDF, and find it very difficult to download it, and it wastes a lot of times. Most of these little observations we have to take when we are going for presentation, make it on the soft word so that it can easily be transferred. And with these littles, we want to thank all the participants for staying patiently and listening. And I don't think for abstract we will ask questions. So I pass the microphone to the chairman. Thank you very much.
Thank you very much. Will all the presenters be upstanding so that we can approach them properly? All the presenters, please be upstanding so that we can appreciate you properly. Thank you very much. Thank you very much. We are moving forward. There is no gainsaying. There's no gainsaying that we are making progress. And I can assure you that between yesterday and today, the level of progress we have made in hospital practice, you can't quantify it. So I want to say congratulations. And we're going to, the presenter should come forward. Let's take a group photograph so that we can go to the next phase. In doing that, let Gwagwalada, the University of Abuja Teaching Hospital, should get ready and kick off the second phase. While the second phase is going on, the assessors will go around the posters to beef up and to conclude the assessment for the presentations that we have had. Thank you. So please, presenters, come up stage. Let us have a group photograph. Yes, results will be delivered during the dinner. DJ, thank you. DJ, thank you. You do more of that later in the day at the dinner. The results will be announced at the dinner. So, we're ready for the second phase of the presentation. Akelikunu, so you're going to announce the ground rules, Abi? Or you have already announced it? Huh? 7 minutes down. No, we don't have 7 minutes. We have 5 minutes. Presentation will be over 5 minutes. So you choose the slides you want to show to us and be... Gabriel, how many facilities? Sorry, 11 facilities times 5 minutes. That's almost 1 hour. I want us to be here, to be off here latest 12:30. Because we'll have eaten too much into another time for the AGM. AGM is coming up. So 5 minutes. Show mastery of your presentation. Even if you are presenting by proxy, just show mastery. And you are the one who want to determine what you are presenting. And then, of course, your slides are available to the assessors. They will look through it and do your assessment as appropriate. So we're starting with Teaching Hospital Gwagwalada. Steve, please come. All right. So we're going to start with General Hospital, Maitama, Hafsat Ahmed Abdullahi. Sorry, we have had some more consideration. We have agreed on 7 minutes. Thank you. Can we borrow one person from the other group, the timekeeper? Luca, you will double as timekeeper. Huh? All right. IT, are you ready? When it's 5, hello, Luca, when it's 5 minutes, you give her a warning. 7 minutes, she stops.
Chairman and the House, Good morning, everybody. Standing on the existing protocols, my name is Pharmacist Hafsat Ahmed Abdullahi, and I will be making this presentation on behalf of Maitama District Hospital. The topic of my presentation is Pharmaceutical Care Services in Maitama District Hospital. These are my outlines. This is introduction. The Federal Capital Territory Administration, which is the FCDA, has 16 secondary facilities across various area councils, which is supervised by the HMB, Hospital Management Board. The hospital was commissioned on the 3rd December 2001. This is the overview of the hospital. These are the services rendered in the hospital. The structure of the pharmacy unit. The pharmacy unit has various units, which include the box store, logistic and supply chain management unit, the active pharmacy unit, the GOPD, and the rest. This is the flow chart for communication. From the HOE pharmacy to box store, there is a two-way communication. From the box store to the active store. The active store now issues the satellite pharmacy, which eventually provide the pharmaceutical care. This is the HOU pharmacy unit, which I call the engine room. The logistic unit, this is the store, and this is the documentation area. The active store, the box store, what they do is they deal with quantification and forecasting, product selection in accordance with essential medicine stores. Then this is the active store, the store unit, and the documentation area. As I mentioned, the active store supplies the satellite pharmacies. What happens is the core operations in the satellite pharmacy, when the prescription come using the EMR, that's electronic medical record, it is screened and validated. Then after the screen and validation, if there is any encounter or intervention, any drug therapy problem, it is intervened. Then counseling and dispensing, and documentation and follow-up. This is what happens generally in the satellite pharmacy. These are GOPD pharmacy, the inpatient, the pediatric pharmacy, the ANC pharmacy, the ARV pharmacy, the pharmaceutical care stroke drug information unit. This is where all pharmaceutical care activities are coordinated. The pharmaceutical care units, they deal with they coordinate the clinical presentations and other activities in the pharmaceutical care unit. Then our A&E pharmacy, which is in the pipeline. This is our winning team. We have 90 registered pharmacy, 10 interns, 1 copper, 3 technicians, and 3 assistants. These are our fellows of the West African Postgraduate College of Pharmacists. Our compounding unit. In the compounding unit, we do extemporaneous preparations, hand sanitizers, cream, and these are our compounding unit. And our label is here, the hand sanitizers. Then the training. For training, we do clinical meetings and presentations weekly. And during the clinical meetings and presentations, we do pharmacists, interns, coppers do presentations, then drug companies, then step down of workshops. These are some sessions of our clinical presentations, pharmacists presenting. These are some of the topics presented. For our trainings, we train interns, residency training in the WAPCP, and IT training. This is a package of our IT training, orientation, assigning of a preceptor to the interns, and etc. Then these are some interns making presentation during our clinical meetings. And the interns are, with outstanding presentation, are appreciated by our HOU pharmacy. These are, then we have innovations, which we do in Maitama District Hospital recently. Some of our innovations, we take our interns to training at various units of the hospital so that it will increase our collaboration with other units and it will make them learn better. We have gone to A&E unit, dental unit, ECG unit, ENT unit. Then we do non-pharmaceutical trainings, like we train our interns on how to print and photocopy too. These are our documentation tools, the intervention forms, the patient encounter forms, the pharmacovigilance form, the clinical ward round, the patient follow, health talk, compounding. Then we also do some research have taken place at Maitama, like the health eats research, the NICADE AMR research, which is still ongoing. Then pharmaceutical care activities has greatly improved in Maitama Hospital. with the e-clinic, that's the electronic medical record, because we can see the case notes and we can see the vital signs, the medical record, which has also improved our follow-up. Then you can even see the drug history with the electronic medical record. Then these are some pharmacists at Clinical Wardroom, some pharmacists at Health Talks. Then a pharmacist is here using the intercom and communicating with the physicians and other healthcare workers like the nurses on interventions and clarification on medications. Then sample of our intervention. These are some drug therapy problems, because at the end of the month we do a report. This is a particular month for drug therapy interventions. Our professional development, our pharmacists go for programs like MBA, MSc, WAPCP, and the rest. We go for workshops and seminars, and we're being rated by the FCT monitoring team on monthly, quarterly, and annual ratings. Then it's our rating. My tema has come second position in 2018. And recently, we were awarded the best unit in ensuring strict compliance with COVID-19 protocols. The hospital, even though it will be 20 years, has also gotten a lot of awards, the hospital itself. These are our vision, our strength, our challenges. In conclusion, pharmaceutical care practice at the pharmacy unit has a high positive impact on treatment outcome of our patients at Maitama District Hospital. And anything not documented is not done. And if it's anything that is not documented, anything not documented is only God that will say that yes, it's actually documented. So my references are from the documentation tools of our pharmacy unit. Thank you.
Please, a round of applause for her, please.
Yep. The next hospital is Gwagwalada ready? Are you ready now? Okay. Dr. Henry, please, can you join us here? Join us here. I'm sure you have enough hands to go to do that. Hello. Any difficulty? Hello? Okay. while you find another device. Hello? Hello? Please, can the presenter, Dr. James Regina of University of Uyo, step up to the podium while that is being sorted out?
I am here to present on behalf of the University of Uyo Teaching Hospital. That is my outline, introduction, and the rest. We have a mission in the hospital. And we exist to provide quality healthcare services and manpower development in a compassionate manner.
Hello?
Now, the structure of the department.
Please. We will give you time to start all over again. Dr. James, we will give you time to start. It looks like the noise level in the hall is...
Okay, in the hospital, we have the head of department and we have 5 divisions in the hospital. One division...
The noise level in the hall is increasing. Please, can we all be muted?
Okay, please. We have...
Dr. James, I'm protecting you. I said you stop. I'll tell you when to start. Better. The noise level is increasing. Please, the Deputy President North is in our midst and is helping us. So I assume that we will also listen to him. Thank you. Especially people at the back. Thank you very much. Dr. James, you can begin.
Good morning, distinguished guests, distinguished pharmacists. My name is Dr. Regina James. I'm here to represent University of Uyo Teaching Hospital. Our structure is such that we have the head of department who supervises everything about the pharmacy department. We now have 5 divisions, including clinical pharmacy practice, quality control and production. We have public health. We have training and education. We have administration. Those are the heads of the various divisions. As I have already mentioned them, those are their names too, of the various divisions. And then the department has 1 director, I have said, 3 deputy directors, 10 assistant directors, and all of that. All of those people are heads of units. We actually operate a decentralized pharmacy. We have like 17 units, each in a specialized care area. Our pharmacists have additional qualifications. Like we have 10 pharmacists with PharmD, we have 8 with West African Postgraduate Pharmacy. We all do this training in order to enhance patient care. Those are the units, about 17 units, the central box store that actually receives all of the medication and now issues them to the various satellite pharmacies. Those are the names of the pharmacies. We have so many of them according to our specialized area of the patient. We have compounding units that actually produces a lot of things, including bleach, alcohol hand sanitizer, liquid soap, methylated spirit, antibiotic hand wash. This has actually helped the hospital so much economically because the hospital does not need to buy antiseptics anymore. And it has reduced the economic expenses of their hospital. Also, it has promoted the image of the pharmacies, of the hospital pharmacies. Because even the management is amazed that hospital pharmacies can actually go into production of these various products. We also do extemporaneous compounding for our pediatric patients, as was stated here, because there are many other medications that are not in the syrup form. So we go ahead and compound them according to the patient's specific need. That is some of my pharmacists in the compounding units. Those are the products that are produced in the quality control. Also, we document pharmacovigilance activities. Those are some of the documents, some that have been documented. I will not go into that. We also have active drug information services, where we actually give out drug information to the hospital community, to other pharmacies, and to the public. Recently, that has become very hot because we get inquiries from the hospital community, the medical doctors, the nurses, and others, asking us, seeking drug information, which we willingly give out to them. There's also drug manual and guide counseling, what we do. And then the clinical section, activities in the clinical section, we supervise clinical activities in all the units. And then, because those patients in the ward, which you cannot really counsel directly, we engage in ward round. We make out in a week, we have a specific day. On Tuesday, we have general ward round, where all the pharmacists go to the bedside of the patient. That is why we divide ourselves into 4 teams according to specialty. We have the O&G team, the pediatric team, the surgical team, and then the medical team. And in fact, even among the teams, we still have 3 subspecialties, 3 sub-teams per team. This enables us to actually see most of the patients in the ward on Tuesday. Apart from these, 3 specific units go to the ward every day. On daily basis, we go, we interact with the patient, we ensure their adherence, we ensure the appropriateness of their medication. We ensure that their medications are correct, the doses and everything. We go, we work hand in hand, we interact with them, also interact with the medical personnel and the nurses to ensure rational use of our medication. Okay, those are some pharmacists in the ward. We also engage in training. We train the undergraduate pharmacy students that come for clerkship. Some actually come from various other hospitals as an industrial attachment to train under us. We are also preceptors for the West African Postgraduate College of Pharmacy resident students. We also train some pharmacists who are doing postgraduate college in a clinical pharmacy. Those are samples of our forms and interventions we have made. And then, like I said, on Wednesdays, we have clinical meeting where we engage these students that are coming for a clerkship. We engage them. We give them topic to make presentations that will tell us a rationale for the use of certain medication. Also, we take cases in the ward. When we come back on Tuesday, we take cases where we actually find out any drug therapy issues that could not be handled there. This is a picture. These are our interns with us in the dialysis unit, because we take them around the various care areas. We have this poster all over the hospital, and they actually come to us where there is any drug therapy problem. And then we have the education training, like I've already said. They're engaged in clinical meeting training, research, and various others. Some of our staff engaged in training. Also, this is a training that was organized by the pharmacy department. And then we invited a lot of people, and they came. Also, the public health is involved in disease surveillance. They create awareness on World Health Organization days, or disease infection, and all of that. That is that division. For instance, this picture was taken on the World Hypertension Day, where the public health department actually went round creating awareness for hypertension. That's the general outpatient. In our general outpatient, we actually have the subdivision, we have the dispensing, and then also the counseling area separately. In conclusion, pharmacy department in the University of Uyo Teaching Hospital is well organized. It is one of the very high achievements in past and present years, and was judged the best department in the hospital on 2 consecutive times by the hospital management. And we have been winning awards thereafter. Thank you very much.
Please, let's put our hands together for her, please.
Thank you very much, Dr. Regina James of University of Uyo Teaching Hospital. We appreciate you. I will believe that the best is yet to come from that center. Mr. DJ, sir, I'm sure you still need to help us with this sound. You will need to equalize it as best as you can. What we're having here today is an audio thing. When it's time for disco, you will tune it to the right disco volume. But for now, this one is for hearing purposes. Please help us as much as possible. This is the cross of why we are here, and that's why we call it scientific conference. This is the scientific part of it. So we'd like to call on NAFDAC, Dr. Festus Ukadike. Are you in the house? You sat on the wrong side, though. But that will not affect your rating. Gabriel, should I give you like 5 minutes to sort out all those technical issues? All right. While we are doing the technical things that need to be done, let me recognize the presence of pharmacist Munir Elelu, who is a son of the soil, and the Deputy President North. He just walked in, and he has also helped us to maintain some level of making sure that our people remain muted as much as possible. We also use the opportunity to recognize all fellows of the society who are in the house. Please, can you be upstanding so that we can recognize you? Fellows of the society. I didn't say fellows of the college. FPSN. I'm also here. Thank you very much. And as part of the protocol, we also like to recognize all fellows of the college who are here present. Can you please be upstanding for recognition? So please, clap for yourselves. Clap for yourselves. I'm sure a few years back, if you ask for fellows of the college, I'm sure we're not up to this number. We will have been like half or 1/4 of this number. And congratulations and thank you for coming. Because coming here too has been at a cost, which many of us have borne privately. So we want to appreciate you, and we want to thank you. And we want to even thank most especially those who are still in the college, because we had enough reason to abandon that college. But now I can tell you that the reason for abandoning the college is no longer there. You can say hallelujah. You can say hooray. You can sing a new song. And that song is going to be very permanent in our lives. Can I hear amen from somebody? I'm not a pastor, but if you are led in the spirit, you can come forward and drop something on the floor. We're just using all of this to take some time while the technical people sort out the issues with the transmission. Yes, I think my technical people are doing great. And I'm sure some 5-6 years ago, we will have borrowed somebody from outside to come and be doing this. The people you are seeing there are all pharmacists like you, and I please, can I have a round of applause for you? The chief technical officer of this whole IT stuff is Dr. Bello. Please, can you give me a round of applause? So this is part of the development we're talking about. I'm sure if we take a census of people who are here, those of us who have postgraduate degrees are more than those of us who have job-based degrees. That's not true. So I think we need to give ourselves a pat on the back. Congratulations, everybody. I think Gwagwalada is ready now. Gabriel, is Gwagwalada ready? The devil is a liar. At University of Abuja teaching us. The devil is a liar. The devil. Maybe the memory of that computer is already full. But I thought it was MS PowerPoint. Unless there are various versions. You don't need to convert to PDF. Even me, I don't like PDF. I like MS Word.
You are set. Your time starts, please. Sorry, starting.
Are you good to go now? Yes, sir. Thank you.
Sorry for the technical issue. She's standing on the existing protocol. This is presentation from the University of Abuja Teaching Hospital. The technological advancement in pharmaceutical care delivery services in UATH. That's our logo, the outlines. UATH was established in 2006. It's a 500-bedded hospital with over 16,000 patients turnover per month. The workforce of the pharmacy department include resident pharmacists 32, intern pharmacists 23, no NYSC pharmacy, fellows of West African Postgraduate College of Pharmacists are 13. We have about 13 satellite pharmacy within the hospital. That is a pharmacist in the theater pharmacist. And our pharmaceutical care activities, services cut across all the units of the hospital. We have mini compounding units, mini manufacturing units, distinctly distinguished from the compounding unit. The products we produce, we produced about 13 products that is being used by the hospital, which include the bleach, we call it Uadzone. We have our antiseptic hand wash, Uatol, and the rest of them. You see the picture as we proceed. That is our bleach produced in the hospital, the paracetamol, morphine 500 mils, morphine 250 mils, bleach produced ready to move to the box store, antibacterial hand wash, Izal, what we call Uazal, the germicidal agent used in the hospital. This is pure antiseptic. The parent's name is the Purite, what you used to know as Purite, is used in the theater. This is the production unit. Pharmacist Telzing, the head of unit, and pharmacist Steven carrying out the production. This is our methylated spirit. This is the quality control unit of the hospital, doing comparative studies and checking the quality of the product after some time. The compounding unit of the hospital is very distinguished, and we have, among the drugs compounded, spironolactone is the one with the highest frequency, and the ones with the lowest frequency include gabapentine, aceclofenac, and the rest of them. This is the chart of the frequency of production of compounding within the compounding unit. That is the pharmacist faithfulness compounding in the compounding unit. This is our oncology unit. And Drug and Therapeutic Committee is responsible for the hospital formulary and due for review every 2 years. Purchase and procurement is based on drug hospital formulary. The pharmacovigilance activities of the hospital takes place in every unit as mentioned earlier. It's a continuous process, and the pharmacy department presented on pharmacovigilance and adverse drug reaction reportings during the continuous medical education program of the hospital last year. We have, till date, 3 reports this year on pharmacovigilance. These are the pharmacovigilance report forms sent to NAFDAC. And training and clinical activities. The training is for all interns, IT students, students of the West African Postgraduate College of Pharmacists, and the resident pharmacists. The training takes place weekly, from weekly presentation, unit presentation, research project, and departmental presentations. This is one of our presentations. The audience, the pharmacists present during presentation. So, our research work. We have over 50 research work carried out in the department, but few are published. We have, to our credit, 3 published work from the Global Health Network for Clinical Research Club, which is a general club, multidisciplinary club in the hospital, but largely driven by the pharmacists. The number of case studies documented over the period of time is 37. Corticosteroid-induced hyperglycemia, asthmatic management in patients, and oral thrush, which is very interesting. I'll talk a little about this. Oral thrush in patients with leukemia. This case was a classical case. The consultant in charge of this unit, pediatric unit, had to approach us in the pharmacy department compounding unit to compound a product for them. But the formula they brought was wrong, so we had to change the formula and produce for them what we call viscous lignocaine. That is the picture of the little girl when we started the medication. After 6 days, laboratory results, after 6 days, you will see the outcome of the patient. You will see that the oral thrush had improved. So, pharmaceutical care activities in the hospital. Pharmaceutical care activities in the hospital. We have over 100 interventions that have been documented. But I must say at this point, based on our patient turnover, this documentation is a gross underreporting based on the volume of patients we have. So we engage to do more. We have a pharmaceutical care form designed in the emergency pharmacy. We have about 9 of those forms available. Pharmacy Kufre, can you please help give out those forms? It might be helpful for other hospitals. Help us give out those pharmaceutical form intervention. This is our pharmaceutical care notebook. And the units in the wards are 6. At the ground round, we have ground round, and we participate ground round in only nephrology department. 2 pharmacists and 2 interns go on ward round. But I must mention at this point that some interns, a lot of the interns run away during ward round because of the rigor of ward round. Ward round, you can start ward round around 10 and end by 3, and you will be standing on your feet. So, the challenges of ward round: gross shortage of pharmacist personnel, attitude of some medics, lukewarm attitude of pharmacists to ward round, frequent internal posting of pharmacists from one unit to the other. We have the number of interventions we have done so far is 67, and the number of pharmacists in the ward is 15. The pharmaceutical activities was successful through the cooperation we received from other professionals, doctors, nurses, and the management. And this was achieved through diplomacy, politics, and proper administrative procedures. These are our pharmaceutical care notebooks, reports. And we have what we call Pharma Council, what some other people call health education. We christened it as Pharma Council. We do it in the NHIS complex and the GOBD complex. This is a picture of some of those activities during Pharma Council in UATH. Limitation: gross shortage of pharmacists, burnout of the few pharmacists at work, failure to document pharmaceutical care interventions regularly, lack of appropriate pharmacists charged with the responsibility to implement pharmaceutical care intervention documentation, pharmacists failing to own pharmaceutical care. The team, without the team, it wouldn't have been possible. Thank you. And our appreciation goes to our management.
Please, a round of applause for him. Let's put our hands together for him. Thank you.
Thank you very much. Is NAFDAC ready? Dr. Bello, NAFDAC is ready. Okay, after NAFDAC, which people? Don't score NAFDAC. Hello, Dr. Bello. What's the hiccup? 1 minute.
the chairman, colleagues here present, good afternoon. My name is Dr. Festus Ukadike from NAFDAC, from the Directorate of Drug Registration and Regulatory Affairs. I want to inform us here that NAFDAC is also involved.
Hello, sir. Dr. Ukadike, please slow down. Hello. Please, I think the voice level at the background is so high and it's already conflicting with the presentation. Please let us let's listen. Let's be attentive. Hello, madam, that corner. Presenter, please. Thank you. Please go ahead.
Thank you. Almost everybody has spoken about pharmaceutical care. I want to inform us that NAFDAC is also involved in pharmaceutical care. Because we prevent potential drug therapy problems by ensuring that the drugs that we release are of good quality, safe, and efficacious. And so today I want to share a few slides with you in the efforts that we make in strengthening regulatory systems in NAFDAC. Well, drug regulation is dynamic. The way we operated 10 years ago is not the way we are operating today. In like manner, strengthening is a continuous process. We can never come to a stage where we say, okay, we will stop improving at what we do. We will continue to go on to evolve ways of making our job better. Today, I'm going to, my outline, we have introduction, we have the NAFDAC mandate. Then we will discuss quality management system as one of the ways we adopt to strengthen our regulatory systems. We will discuss CTD dossiers, common technical document dossiers. We will discuss WHO global benchmarking tools. Then we will discuss pharmaceutical traceability. NAFDAC mandate. NAFDAC is mandated by law to control and regulate drugs, foods, medical devices, chemicals, packaged water, which we call regulated products. Okay. So this outline we have already taken. We have taken this introduction. I have informed us that national regulatory agencies the world over are constantly evolving new ways of ensuring that drugs in the public space are of good quality, safe, and efficacious. Effective regulatory systems are essential components of health systems. They contribute to desired public health outcomes and innovations. Countries in different regions come together in blocks to adopt common ways of regulating medicinal products. This is the NAFDAC mandate I've already informed us about. Now, we have different directorates in NAFDAC. We have the technical directorates. We have the non-technical directorates. The whole agency, as we know, is headed by the Director General, then followed by the directors, followed by the divisions. Each directorate has at least a minimum of 5 divisions. Quality management system is the summation of procedures, processes, and policies which an organization like NAFDAC consistently adopts to meet customer requirements and enhance their satisfaction. In QMS, we used to quote Edward Deming that it is not enough to do your best. You must know what to do, then you do your best. These are the principles of quality management system: customer focus, leadership, engagement of people through continuous improvement to relationship management. Now, NAFDAC attained ISO 9001-2015 in June 2019. Since then, we have not looked backwards. The benefits include improved customer satisfaction, competitive edge, better documentation. Like someone said earlier on, if it's not documented, then it's hearsay, it's story, it's rumor. Greater quality awareness, positive cultural change, enhanced communication. Then common technical documents. NAFDAC has implemented the use of common technical document dossier format in line with the recommendations of ICH, International Council on Harmonization of Technical Requirements for the registration of pharmaceuticals for human use. You can see the different modules of the CTD triangle. Module 1, who speaks about the regional requirements. Module 2, quality, quality overall summaries and overviews. Module 3, quality. Module 4, non-clinical study reports. And Module 5, clinical reports. CTD is a set of specifications for an application dossier for the registration of medicines. Full implementation of the CTD format requirement for submission of dossiers in support of marketing authorization applications had commenced. Global benchmarking tools. This is the primary means by which WHO objectively evaluates regulatory systems. National regulatory agencies are rated on a scale of maturity level 1 to maturity level 4. I'm glad to inform you that NAFDAC is set to clinch maturity level 3 by December 2021. The tool and benchmarking methodologies enable WHO and ROAs to identify strengths and areas of improvement, facilitate the formulation of institutional development plans to build up strengths and address identified gaps. Pharmaceutical traceability. National Pharmaceutical Traceability Strategy. NAFDAC implemented a scalable project as part of the regulatory strengthening and underscoring of its mandate in conjunction with National Primary Healthcare Development Agency and GS1 Nigeria. COVID-19 was used as, for a pilot study, and it was tracked through healthcare supply chain. Conclusion, NAFDAC is a forward-looking organization. Strengthening regulatory systems cuts across all the directorates. Quality management system is fully entrenched. NAFDAC continually strives to achieve a mandate of ensuring that regulated products made available to the consuming public are of good quality, safe, and efficacious. Thank you.
Please, a round of applause for him. Thank you, sir.
Thank you, Dr. Festus. The next institution is Adeoyo Maternity Teaching Hospital. Maternity Teaching Hospital. State Specialist Hospital, Oshogo, should get ready, followed by University of Ilorin Teaching Hospital.
Okay. Good morning, members of the high table and pharmacists present here. My name is Olubukola Ainde. I'm an employee of Oyo State Hospital Management Board, and I currently work at Adeoyo Maternity Teaching Hospital. And I'm going to be showcasing our activities at Adeoyo Maternity Hospital. Let me just start by saying that Adeoyo Maternity Teaching Hospital is a state-owned general hospital involved in providing maternal and child health services to people in Ibadan and its surrounding. and then it's about 200 bedded hospital. My slides are majorly pictures, and I'm going to be speaking to it. That's a picture, a side picture of Adeoyo Maternity Teaching Hospital. And that's a picture of the pharmacy department. It's on the ground floor. And that's the winning team of Adeoyo Maternity Hospital. It's made up of a deputy director, an assistant director, a chief pharmacist, three principal pharmacists, corpers, and 3 technicians. And then we have 3 graduates of the West African Graduate College of Pharmacists in our team. That's the vision statement, which is placed in every satellite unit of the pharmacy department. It says to help our clients regain their comprehensive health with utmost dispatch at optimal cost to achieve remarkable quality of life. And that's our mission statement. And these are our core values, which we cherish very much and always ensure that every person in the pharmacy department imbibe. That patients come first. Professionalism is key. We are a core team in the healthcare to show empathy to patients, to be transparent in all our dealings, and to ensure collaboration. This is an organogram of the pharmacy department. We have 4 major satellite units. I'm going to be showing them afterward. There is the public-private partnership pharmacy, which is run by the fund manager and provides major drugs in the hospitals. There is also the managed care unit, which consists of the Oyo State Health Insurance Unit and the National Health Insurance Units, providing drug for the health insurance patients. We also have the ARV clinic, also called the PEFA clinic, which caters for over 5,000 patients living with HIV, including male, females, and pediatric patients. And then we have our drug information and pharmacovigilance units. This is what our public-private partnership pharmacy unit looks like, and those are pharmacists and technicians working there. And this is what our drug information and pharmacovigilance unit looks like. And this is our managed care pharmacy units, where we have the National Health Insurance and the Oyo State Health Insurance. That's the patient's waiting area and the main dispensary area. And this is our store area. As we all know, the store is also very key. We have about 4 stores. Each of the satellite pharmacies have their stores. And we also ensure that our stores are up to standard. As we all know that the provision of effective and safe medicine is a responsibility of the store. That's our compounding unit. Compounding has not been going up very much, but we still manage to do a few things there. We produce pediatric syrups for drugs that are not available in syrup form for pediatrics. And during the COVID era, we were able to provide sanitizer for the states and for the hospitals as well. This is a picture of the sanitizer we produced with the state logo there. We made donations to the state governments, and we are also responsible for providing sanitizer for most of the hospitals in the state. On training and our clinical activities, let me say Adeoyo Hospital is involved in training of interns, in training of pharmacy technicians. Oyo State has a school of hygiene and technology that trains pharmacy technician students. And Adeoyo is one of the facilities that provides the compulsory hospital attachment for this pharmacy technician. At least we have about 6 of them around in a year. We also train students on clerkship from the university. And we also provide training for nursing and public health students from Leeds University and Babcock University, especially in our ART center. This is the pharmacy department, the HOD in particular, providing training on infection prevention control for COVID. In fact, is the focal person in the hospital for infection prevention and control. So that's the department making a presentation to the hospital. We have many committees in the hospital where pharmacists are members or heading. The Drug Advisory Committee, the Drug and Therapeutic Committee, which is headed by the HOD of Pharmacy, also has pharmacists as member. The Clinical Review Committee, also headed by pharmacists. Same with the Infection Control, the Pharmacovigilance Unit. We have these other units too in the hospital with pharmacists as members. All over our units, we have standard operating procedures for client complaints, for patient counseling, for product procurement, housekeeping, and dressing codes for members. On World Pharmacy Day last year, this was the celebration. We had an engagement with the hospital management to do more visibility for pharmacy departments and to make every other person aware of the role of pharmacy in the hospital. That's the photo of the hospital with management and other healthcare members and arrays of pharmacies at the meeting. And recently, last month, the PCN paid a visit to the hospital for the purpose of inspection and accreditation. So that's the team in a photograph with the hospital management. And then on research, one of us recently got his PhD thesis published in peer-reviewed journal of Tuberculosis Research. The work is on prevalence of adverse drug reaction to second-line anti-TB drugs in Nigeria, a cross-sectional study. The hospital is also taking a woman trial, which is looking at tranexamic acid for the prevention of postpartum bleeding in women with anemia. It's an international randomized double-blind placebo-controlled trial, and that's the trial team. We have 4 nurses, 2 doctors, and my honorable serve as member of the clinical team. On pharmaceutical care, and let me just say that recently we got approval for ward round as the result of the visit of the PCN to the hospital. Because the PCN made them know that we now have consultant pharmacists. So the hospital agreed that the 3 consultant pharmacists can go on grand ward round with the O&G consultants, which should take up anytime soon. And this is showing some of our pharmaceutical care and the documentation practices. When patients come in, there is a prescription area for vetting of prescriptions and review of prescription. And then there is a dispensing area where the prescriptions are dispensed. And then there's a counseling area and counseling sessions. There's a documentation area for documentation of ADRs and other activities. And aside from work, we also appreciate one another. We give gifts to best staff, and then we celebrate one another during back days and do socializing. Thank you very much.
State Specialist Hospital.
Hello. I think we need to set a few things straight. Please, there will be no clapping during the presentation. Allow the presenters present, no clapping. You want to clap, or clap at the end. Let me also use the opportunity to recognize all the DPSCs who are in the house, that directors of pharmaceutical service from the states. Please, can you be upstanding for recognition? Directors of pharmaceutical services, please be upstanding for recognition. Thank you very much. So, State Hospital Osogbo, please, it's your turn.
Good afternoon, everyone. My name is Dr. Mrs. Olulawal. I'm here to present hospital-based pharmaceutical care practice in State Specialist Hospital, Osogbo, Osun State, Nigeria. We have a 78-bed facility with a decentralized pharmacy department. We have 7 units. Those are the units. That's a picture of the pharmacy department. That's our Director of Pharmaceutical Services, Pharmaceutical, Zonal Director. Those are the registered pharmacists working there. That's a picture of the main pharmacy. A&E Pharmacy, one of the units. I'll be going through the picture of the units. The Hois Pharmacy, that's for health insurance. Hope Clinic unit. Pediatric Pharmacy. The counseling unit. This is an interesting one. In this room, there is no drug whatsoever. It was formed after a study on how we can reduce waiting time of patients. There are some patients that used to hold up the queue when they need counseling, so you just move them to the counseling room. Structure of the department. We have a total of 13 pharmacists, of which 6 are full pharmacists, 4 fellows, 5 interns, and 2 corpers. That's a picture of our intern and corporate pharmacist. We have a compounding unit where we make extemporaneous products, ointment, syrup, some special formulation individualized. We produce hand sanitizers first during the Ebola outbreak. That's a picture of the compounding unit. Then I come to the drug information unit. Here we dispense information on drug and therapeutics to pharmacists, prescribers, other health personnel. We source for our information and dispense such information through text messages, WhatsApp. It can be individually, one-on-one, or collectively when we give public health talks on Wednesdays. Sometimes we do media campaigns, like when there was an upsurge in codeine abuse. So we can go on radio and television, and sometimes we get invited during maybe like World Malaria Day and so on. That's a picture of the drug information unit. That's one of our pharmacists at a live radio program. Then I come to the drug and therapeutics committee. This committee meets quarterly. They are saddled with the responsibility of developing the hospital formulary. Review is being done as necessary and appropriate adjustments are made to the formulary. We have 2 pharmacists representing us on this committee. Pharmacovigilance activities. These are reported and documented and submitted on a monthly basis. Reported ADRs are usually attended to in collaboration with other health professionals and monitored. That's a picture of one of them. I come to training and clinical activities. Our facility provides opportunities for pharmacist training without limits. We have 4 fellows designated as consultants already, and we presently have opening for more. We have 3 master's degree holder, 1 PhD ongoing, and there are a series of draft training relating to duties performed. And where possible, financial incentives are usually included. An example is when we are fully sponsored to Ghana for our induction. That's a picture from one of the training. That's another picture. Then research is conducted. We have several researches. I listed some of them here. I just presented one earlier. Then award won. That's a picture of an award won by one of us for Amolona Day at WAPCP in Liberia 2017. I won one too in Ghana in 2014. Then departmental and clinical meetings. This holds every Thursday. Monthly roster of topics and presenters are usually shared ahead. Trending issues usually take precedence in assigning topics. Like when COVID-19 came, we had to suspend the roster and take it up. Interns are usually paired with the main presenter for mentoring. Departmental and clinical meetings, that's a picture from one of them. Pharmaceutical care activities. Pharmacist World Round is carried out every weekday. We are being led by the consultant pharmacist with findings and interventions documented in pharmaceutical care sheets, placed in patient file for attending physician and nurses to act on. We had to do this because we found out that others are taking glory for what our interventions are. So they said, we have decided to change the drug. They will not say the pharmacist has told us. So what we now did was we got a sheet to place in the patient's file so that anybody that opened it will know whose intervention it was. Sometimes this word round includes medical doctors and nurses who collaborate on critical cases requiring immediate intervention. That's a picture from one of the grad rounds. You can see the nurses there and the doctor. Pharmaceutical care activities. This is a sensitization meeting with pregnant women by a team of pharmacy consultants as a follow-up to increased cases of neonatal jaundice. Word round, that's another picture. That's another picture. Treatment review. Treatment review, we usually do this for patients. Then our documentation tools, we use the SOAP format, the intervention form, we have 2. Those are the pictures of the 2, pharmacy word note and pharmaceutical care sheet. Resolve interventions. I mentioned only 2. There was an HIV patient on admission for 5 days without medications. We discovered this on our first day in the ward, and it was so clear that there was a lacuna waiting to be filled by us. This is our inroad into the ward. The second one was we changed the drug administration time. They usually use 8 hours window, 8 a.m., 2 p.m., 6 p.m. We called attention to this, organized a mini workshop, and it was changed. Number of pharmacists in the ward, we have 1, then 5 consultant pharmacists usually coming from local government arm. The level of acceptance. This practice has received wide support from hospital management, medical doctors, nurses, and the rest. There has been no objection to pharmacist review of patient medication files. Our impact was the strong basis upon which the states readily created and enshrined our consultancy cadre. Our consultant pharmacists from March this year are being paid the monthly specialist allowance by the state government. That's an evidence of it. That's our circular. Then that's a picture of all the doctors in the hospital. That's the most senior consultant in white. It was the one that pushed for us to be able to get the specialist allowance. They usually meet in the pharmacy department every Friday, every week. They usually meet, and I think that's a high level of acceptance from them. That's another picture for collaboration. That's my director there, Pharmacist Fashipe. He's here. He's a fellow of the college clinicals, director nursing, and director of physiotherapy. I thank the management and I thank everybody.
Thank you very much. Another round of applause for Oshogbo. Yeah, thanks. But you will also learn how to refrain yourself from clapping in between because you will only be elongating the time. We will call on University of Ilorin Teaching Hospital. Please step up to the podium. Yeah, please go on.
Good morning, everyone. I am Pharmacist Bameke Kamaldin from University of Ilorin Teaching Hospital. And I'm here today to present to you our practice in University of Ilorin Teaching Hospital, our pharmacy practice. First, how we are rendering pharmaceutical care in the hospital. Second, how we are utilizing technology in advancing the rendering of this care. This is my outline. FIP have defined business statement defining the global best standard. And here I'll be talking how we have been conformed with this best standard. The structure of our department, our pharmacy department is decentralized, and we have about 20 decentralized pharmacy units, as shown here. And part of the FIE statement is that the people that are handling these handling pharmacy units is very important. And here our Pakabebu head of units, including our HOD, Pharmacy Charles, and Wakile. Among them, we have 3 directors of pharmacy. And these are our full statistics. 3 directors of pharmacy, 13 deputy directors. We have several fellows of West African Postgraduate College of Pharmacy. We have several graduates of PharmD. These are main pharmacy. You can see pharmacists discussing the position. Here, you can see patients comfortably discussing with the pharmacist and the patient on one-on-one counseling in our pharmacy medicine unit. These are other units. This is a pharmacy house built by AHAPN UITH. And here, we have a conference room. We have a quality control lab. We have a guest room and several other sessions. These are some of our registered pharmacists, picture of our intern pharmacists. I'd like to go to our combining unit. Our combining unit is highly active. They provide a 24/7 service. They prepare both external and oral extemporaneous preparations. Oral preparation like morphine, paracetamol syrup, and external preparation like sulfurous and salicylic acid ointment, resolve solution, and others. This is a picture of our combined unit. Oral preparation, external preparations. And these are statistics of things we've prepared. You can see morphine, up in a year we can prepare up to about 1,440, can tell about 140 positions. During the COVID period, we are able to produce sanitizers for the hospital and the community, and also the scarcity of PPE. We have people that were able to work on that. This is our pharmacist Olagunju here in Foodie Yard. From here, I'd like to go to our drug information unit. We have an active drug information unit. And part of the thing they do, clinical meetings, disseminating information to the patient, health talk on the need of rational use of drugs, and some other things listed there. And here we have 2 registered pharmacists handling it, in which the head is the director of pharmacy. And part of what they do, they develop a formulary of drugs for the hospital, and they've been reviewing it. Here, I would like to show us, these are drug information units. Picture. This is Ilorin students that came for training with us. a picture of Zoom video conferencing on in our drug information unit. And these are head of drug information unit. These are drug information form, hospital formulary, drug formulary. In fact, this is the old one that was reviewed. Picture of pharmacy rotation by students. This is another picture in front of Gala Ward providing pharmaceutical care. And here I would like to talk about things we've done. Part thing we started far back 2019, therapeutic drug monitoring, antimicrobial stewardship, pharmacogenomics, pharmacogenetics, some other things listed there. And these are important for drugs that have low therapeutic index. These are technologies we've been using in the hospital to advance our care. You can see computerization, radio sensitization, video conferencing. We didn't just jump into anything we want to do in the University of Teaching Hospital to make sure that we have experts that we first talk on it. This is a professor of education technology that first talk about video conferencing, telling us about it even before we start using it during the week of a COVID period. These are part of the things we've done using Zoom. We invited people from like this professor, Josiah Alamu from University of Illinois, to talk to us about comparison of clinical characteristics and outcomes of patients with severe COVID-19. These are other training on advanced practice and tradition in hospital pharmacy. Another training on antimicrobial stewardship. This is a professor again from US talking to us about the management of high-risk medication. Next, part of our using technology, this is a radio sanitation in which people are there. This is just May 17, a few months ago, talking about blood pressure to the community. So part of our presentation of ground round to the whole hospital. This is one of the pictures from the ground round, picture from clinical meeting. And we have our coordination unit. I'd like to talk about it too. University of Nigeria is the zonal pharmaceutical center in the whole Northwest Center zone. And these are things we've been doing. And this is the head of our pharmaceutical unit. And they've really, in fact, the work they've done during the fasting admission period, they've done a really good job because they have to document for the whole Northwest Center zone the adverse drug reactions. And apart from that, these are part of the documented adverse drug reaction they've done. And they were able to invite someone from the United Kingdom to talk about this vaccine, even before they start administrating it. They talk about COVID-19 vaccine, the ingredient type, side effects, and efficacy and safety. This part of our training and clinical activities. Apart from this training, we have both local and international. These are training we've done locally and the clinical activities we've done locally, as shown there. And we have our people that have traveled to overseas to have some training, like pharmacy training. This is oncology training in US. Pharmacist Olaiwaju is there. Our international training in Florida. Training on antibiotics stewardship program. Our pharmacy automation training. Pharmacogenetic training. And these are some of the research that have been conducted and documented. These are paper presentation throughout the country, Lagos, Port Harcourt. These are a number of different case studies and different health conditions. And these are pharmaceutical care, the Ghana we perform regularly. And another thing, we have a mortality and treatment review that we do in the hospital. These are an electronic newsletter talking about pharmaceutical care. And these are pharmaceutical care documentation from our pharmacists are going on one round, which we do regularly. You can see them. This is a picture of go round. And these are part of our pharmaceutical care activity, which we have feedback from patients through the use of intervention forms. And this not only in Ilorin, we provide pharmaceutical care far as Kishi. We have a center there in your state, and Kogi State, Ima, and this is here. That's why the bush, our pharmacists, they don't fear. They go there and provide their care. This is an extent of our impact. And conclusion, the clinical pharmacy practice in UITH is rapidly advancing to meet up with the global best clinical pharmacy practices, despite limited resources. Thank you.
Yep, thank you. Another round of applause. FCT Health Insurance Scheme. And General Hospital Gwarimpa to be ready. FCT Health Insurance Scheme. After this, Gwarimpa General Hospital.
right. Good afternoon, the members of the high table, fellow colleagues. I am pharmacist Adedeji Fatai Oladimeji, Deputy Director and the head of units of MIE of FCT Health Insurance Scheme. Before I go ahead, I want to say that I would not have been privileged to be here today to talk about health insurance if not for the dynamism and the visionary leadership of our former director and the current Deputy National President of PSN, in person of pharmacist Munir Elelu, who was the pioneer project manager of the FCT Health Insurance back in 2007. We have written on his background, and today we have 7 different pharmacists who have worked at various times at the FCT Health Insurance. So my outline is thus. Number 1, what is health insurance? Why health insurance? Health insurance is a system for the financing of medical expenses by means of contributions or taxes paid into a common fund to pay for all or part of health services specified in an health insurance policy. And these are the common key elements of any health insurance policy. All these listed here are the common key elements of any insurance policy that is practiced anywhere in the world. Then why do we need to have health insurance? UHC provides that all people have access to the health services they need when and where they need them without financial hardship. Achieving UHC is one of the targets the nation of the world set when adopting the SDG in 2015, and this was reaffirmed in UHC General Meeting of 2019. With over 100 million becoming impoverished annually due to catastrophic health expenditure, strong financial framework becomes imperative, hence the need to institute and strengthen health insurance. And that's led to the establishment of the National Health Insurance by an act in 2004. And the key elements in health insurance is benefit package, which varies from one health insurance agency to another. Then we have the partial and total exclusion in the scheme. We also have the stakeholders in health insurance, which are basically the health insurance agency itself, the third-party administrators, that is popularly known as HMOs. We have the healthcare providers, which are the people who have been speaking all the while. And of course, we have the enrollees. Then we have different provider payment mechanisms in health insurance. We have the capitation, which is a fee paid in advance before the health is received. We have the fee for service. We have the per diem. We have the administrative fee. We have co-payment, and of course, we have co-insurance. These are the different payment mechanisms under which health insurance operates. Then presently in Nigeria, there are basically 4 challenges with the implementation of health insurance. 1 is lack of awareness. 2 is poor acceptability. 3 is the knowledge gap. And 4 is poor political will to entrench the policy. Then, of course, we have the Basic Healthcare Provision Fund, which is another policy of government to ensure that financing of health is taken care of. It's taken away from the patient, and they have different gateways. Now, going to the FCT Health Insurance itself, that is our headquarters in Abuja, located in Central Business District. The FHI is a statutory body established under the FHI's Act 2020 to regulate and provide health insurance to the FCT workforce and all FCT residents. In line with the provision of the government that each state should establish our own health insurance agency, FCT was the first to respond by operating the body in 2007 under the pioneer leadership of pharmacist Munir Elelu, the current Deputy National President of PSN. I think it deserves a round of applause. Now, major giant strides of FHS in the last 3 years include the review and production of working documents, chief of which are the drafts of the FHS Act, the operational guideline, the standard treatment guideline, and referral protocols, strategic work plan 2020 to 2024, and the annual operational plan and benefit package. We have established a standalone call center to react to concerns of our enrollees. And of course, we are engaged in a lot of advocacy visits to traditional rulers, communities, associations, religious bodies, and those are the pictures that you have there. And I'm bold to say that FCT Health Insurance is the only body that is allowed to place its billboard on the pedestrian bridges in Abuja. They were in partnership with FC Microfinance Bank to aid people who cannot afford it. These are our enrollment statistics so far. As of 2018, we don't have any informal enrollee in the scheme, but today we have 1,240 and it's counting, while we have been doing very well with the formal sector. In conclusion, there is no doubt that nations who have adopted and strengthened health financing through health insurance have the best indices for health. It is therefore imperative for Nigeria to toe the same line if she is to achieve universal health coverage. The FHI is committed to taking health insurance to the nooks and crannies of FCT in a quest to fulfill our mandate. Never mind that I've been talking as health insurance agents, I remain a pharmacist. Thank you very much for listening.
A round of applause.
Thank you very much. Thank you very much. We will call on General Hospital Gwarimpa. Medical Center Yenagua be on the queue. After which University of Just Teaching Hospital be on the queue.
Good afternoon. Good afternoon, my senior colleagues and colleagues in the House. I'm Pharmacist Biola Nurat Ahmed Ajenefuja. I'll be presenting on technological advancements which we have made in the pharmaceutical care delivery services in Gwaripa General Hospital. Under this, I'll be talking about my outline. We have the introduction, the role of technology, the advances we have made, and a case study. Gwaripa General Hospital is located in Life Camp in Abuja. It is one of the 14 general hospitals that provides secondary care like Maitama District Hospital too. It is a 105-bed facility and offers a host of medical services, and it is equipped with a functional internet service for adequate patient care. This is a picture of the hospital. This hospital boasts of a standalone ultramodern pharmacy unit, which is one of the best in the FCT. It has counseling rooms for each patient so that there is privacy with the patient and the pharmacist. It has a compounding room. It has to carry out extraperitoneal preparation, a conference room for weekly continuous medical education. The unit is also dedicated to the care of the elderly. With this, we created a geriatric pharmacy, a counseling room for the geriatrics, so that we can fast track, because we know they are the vulnerable group, to fast track their counseling, and there's a focal pharmacist that is always on ground to attend to them. This is a picture of the pharmacy. This is the assessment table where the prescription is evaluated. These are the counseling rooms where we talk to the patient privately. Pharmaceutical care is the responsible provision of drug therapy to achieve definitive outcome. So we know the expected outcome. So what are the advances we have made? We have been able to assess patient data and prescription. We have been able to carry out our documentation properly and conduct medication therapy. Under the access to patient data and prescription, we have the Smart Clinic app, which is the app we use. This app is patient-specific, so there is no error arising from patient bearing the same name. It also has a message tab, which allows the physician to send a quick message to the pharmacist regarding information about a patient or about a patient treatment, or for the pharmacist to interact with the physician. Overall, patient waiting time has been reduced. And with this advancement, we can view patient medical history, laboratory tests, consultation history, radiological reports, all can be viewed, and less time is being spent on verbal conversation with the patient. This is an image of the smart clinic. You can see there under the pharmacy, you see requests. Under the request, we have completed requests and we have uncompleted requests. That's the request that has not been attended to. So once we are done with dispensing to the patient, we click on completed request and we click on it and the prescription goes to completed request. So it can be viewed under uncompleted request. So that anytime a patient comes, we want to find out whether the patient has gotten his medication or not. It's just to go under the completed request to know that. Also in our pharmaceutical care documentation, this has helped greatly with this technology. There's now a timely delivery of the report to the appropriate quarters. Just with the click of a button and we get all the information we need. We have a form that is filled online in which you know the number of patients we attend to is labeled, is numbered 1 to 30. That's the first day of the month to the 30th day of the month. The classes of drug we give the patient, the route of administration, and the number of drugs that were dispensed, when they are not dispensed, and even drugs that were available, but perhaps the patient didn't have enough money to buy it. So we'll put it under medicines available but not dispensed. So with the click of a button, we can get this information. And this is our encounter form for the assessment table. So as I was talking about the technological advances, we have advanced in patient prescription review because of this advancement, because since we can assess patient medical history, so pharmaceutical intervention and substitution are very easy for us, because since we can see the laboratory reports, we can see the, an example is the MCS. We already know the result of the MCS, so if we don't have a particular antimicrobial, and we can substitute easily because we already have the result. Also, interactions such as drug-drug interaction, drug-drug disease interaction can be viewed. An example was a patient we have in this recent outbreak of cholera in Abuja. This patient was not thriving well like other patients with the 300 milligram start dose of doxycycline. And they keep changing prescription, they keep changing the antibiotics to the extent that they were using 3 different antibiotics. But when we viewed the patient medication history, we realized that this is a peptic ulcer disease patient who is on PPIs and antacid. And we know that the Vibrio cholera organism thrives in an alkaline condition. So that was why the patient was not getting well and his condition was deteriorating. This is the image of the smart clinic, the consultation history, how we can view it. This is the radiological report, how we can view the radiological report. This is the laboratory viewing. Then with this medication therapy, with this technological advancement, we can do medication therapy follow-up and monitoring. There's a dedicated helpline in which the number is spread all over the hospital and available to patients. It's a 24-hour line where the patient can call for drug usage information, also for other members of the healthcare to call for any information they need. Also, we can follow up on vulnerable patients like the geriatrics and the pediatrics. Then we can liaise with other units that are being, we can liaise with different units for patients that are being co-managed by multiple professionals. Then we'll be able to do medicine reconciliation, because there are some patients that at that time they came, they didn't have enough money with them. So when next they come, we can quickly go back to their prescription and see the completed one so that we'll know which drugs we've not dispensed to them. Also, we can evaluate our consumption pattern, and this has aided in curbing out our out-of-stock syndrome. Another one is our inventory management. So with this, we'll be able to activate the push and pull system with other sister hospitals so that there won't be any issue with drugs being piled up while another hospital needs it. Then with this, we can give information to NGOs that contribute, that donate drugs to us, like the CHAI. They rely on our information for them to supply the drugs we need. So with this, we carried out a research because we realized that there were some particular antibiotics that were being prescribed more frequently than the others. So we carried out the research in conjunction with the lab, and we realized that most of the UTIs they are treating, they were not getting the MCS was not being ordered, because at the end of it, we realized that most out of the 701 samples taken, only 235 yielded growth. And these are people that they've already commenced antibiotics, so which means not all UTIs are supposed to be treated. There are other interventions like use of probiotic that would have helped. But we couldn't have gotten this without the technological advancement. So in conclusion, the advancement in pharmaceutical care delivery in Guaripa has broadened the scope of practice of pharmacists. Desirable outcomes have been achieved, which has improved their quality of life. It has also helped to foster a good professional relationship. We have some pharmacists among us in which head of unit, like the head of medicine, won't go on ward rounds without that pharmacist being present. And it has improved patient confidence in pharmacies, and we're not seen as just mere dispensers, but as an important link in the healthcare. And also it has reaffirmed, like the research we carry out in lab, it has reaffirmed our position as a frontliner in the stewardship of antimicrobial crusade against antimicrobial resistance. Thank you.
Thank you very much.
Thank you very much. A round of applause for Nurat Abiola Ajeni Fuja. It is the turn of Federal Medical Center, Yenagoa. University Teaching Hospital, be ready. While that is going on, are there pharmacists who work for NGOs that are here present? Is there any pharmacists who work for any NGO here present?
Yes, sir.
Non-governmental organizations. Is there any pharmacist working in any of those organizations that is here? I'd like to meet with you after this program. All right. Federal Medical Center Yenagua is set. Good to go.
Good afternoon, colleagues. My name is Dr. Azate Mwesi, representing Federal Medical Center Yenagua, Bayelsa State. These are outline, mission and vision of the hospital. This is FMC Yenagua. We also have an annex in Otueke. This is the DPSC's office. This is the conference room for pharmacy department. We run a fully decentralized pharmacy, having 15 satellite pharmacy units, which includes the administrative unit. We have the public health pharmacy, which also serves as the South-South Zonal Narcotics Center. We have the vaccine pharmacy. We have a total of 64 pharmacists in the department, and also we have other staff of the department. We have 17 pharmacists of the department who are fellows of the West African Postgraduate College of Pharmacists. We have 1 PhD holder. We have 10 master degree holders. We have 13 holders of Doctor of Pharmacy and 14 currently undergoing other trainings. This is the compounding units of Federal Medical Center, Yenagua. The activities that are being carried out here include preparation of how to get medications. We also produce hand sanitizers. We produce distilled water. We also, all our activities are being documented. We also produce bleach, sodium hypochlorite for the hospital. This is just a picture of distilled water being produced and hand sanitizers. Also, our compounding unit is fully equipped We have our weighing balances, distillation machine, water bath, we have conical flask and others. For a period of 1 year, August 2020 to July 2021, we did a total compounded product of about 656. The Drug Information Service, this is a picture of the unit. What we do here, we provide drug information to patients, caregivers, healthcare professionals. We also involve in researches. We carry out pharmacovigilance survey. We also attend to questions from other people who request for input. These are the tools we use to operate as a unit. We have the SOP being produced by the DIS unit of the hospital that we use for our daily running. We also have a pharma info bulletin, which gives us a brief idea of what we do in the department on a monthly basis. We have the drug bulletin also, which we give to physicians that they use that enables them or serves as a guide for prescribing. The drug information units also carry out researches, as I said earlier. This is one of the research we did. We also have a functional drug and therapeutic committee being chaired by our DPS and HOD, Dr. Daniel Oruense. The members of this committee, they include other clinical personnel, and this committee meets on a quarterly basis to deliberate on issues. This is our hospital formulary. We also have a functional pharmacovigilance committee. They meet on a regular basis. And also what they do is to report all ADRs, both potential and actual. This is a picture of one of the pharmacovigilance reports, a case of Stevens-Johnson syndrome. We also, training and clinical activities were involved in researches. These are also researches we did. One of our research was also presented during the Bayelsa Health Summit held this year. Trainings continue. Weekly clinical meetings and presentations being done on Tuesdays. We do have a yearly ground rounds. We also train students from the Niger Delta University. We also train interns. We also, our hospital is being used as a site for WAPCP residency. We also do a clinical exchange program in the University of Nigeria Teaching Hospital, Enugu. These are pharmacists after world rounds deliberating on issues. So far, we had about 385 documented cases for a period of 1 year. These are case notes. Pharmaceutical care activities. We carry full pharmaceutical care activities in the hospital because we have access to all patient folders. We also interact with our patients. We get information, not minding what is captured in the patient file. We also do our clerking, take proper history of our patient, look out for drug therapy problems, and others. Our innovations. Sorry, this is also the form we use for our ward rounds and interventions. Our innovations include improvement in drug delivery pre-pack services with subsequent inclusion of emergency drug box, creation of pharmacy suggestion box, creation of patient billing form. We also use e-dispensing with the help of Health in a Box software. FMC Yanagua also houses South Zona Narcotic Hub, Vaccine Distribution Center. These are some of public health pharmacy, that's public health pharmacy, Invata, and other. Thank you.
Thank you.
Another round of applause for the presenter. Yeah, we have come to the climax of today's presentation. At least in the next 10 minutes, we should be transiting to another program. So it's the turn of Jos University Teaching Hospital to make his presentation. Jos University Teaching Hospital. And that is the last presentation. The last presentation is coming from Jos University Teaching Hospital. While they are setting up, I'd like to inform you that the Association of Hospital and Administrative Pharmacists of Nigeria, AHAP, we have this drug information center form that has been adopted, and the e-copy will be circulated to all centers. Further details will be provided as we get along. Yes, you are free to go on, sir.
Good afternoon, members of the high table, my senior colleagues, and my colleagues. Okay, and my colleagues. I'm here to present for Jos University Pharmacy Department, Jos University Teaching Hospital, on the activities of pharmacists. The objectives of these presentations are: one, to know the activities of pharmacists in Jos University Teaching Hospital. Two, to know the accessibility of pharmacists to the wards in Jos University Teaching Hospital. Not only the wards, to the patients and also to the folders of the patients. This is the main gate of the Jos University Teaching Hospital. This is the front view of the Jos University Teaching Hospital. This is the main entrance to the Jos University Teaching Hospital. Once you pass through the main entrance, the first department you will see is the pharmacy department by your right. This is the main entrance, and then this is the pharmacy department. In the pharmacy department, we have the OPD stroke, the NHIS pharmacy. And this is the waiting area for patients to collect their drugs. The pharmacists in Jos University Teaching Hospital are fully involved in pharmaceutical care. And also the pharmacy department is decentralized. It has a decentralized unit in all the wards. We have 29 registered pharmacists, 21 are fellows of the West African Postgraduate College of Pharmacies, while 8 are going to be fellows very soon. Then we also have 46 number of interns. We have 2 pharmacists on national assignment. In the pharmacy department, we have offices, and these offices are offices for pharmacists that are involved in coordinating the activities of the department. We have the HOD's office, the pharmacy registry. In the pharmacy registry, we have staff of admin that also are involved in administration. We also have the coordinator narcotics, National Health Insurance Scheme, and EDRF. We have coordinator drug logistics and supply chain management. We have coordinator pharmacovigilance and drug safety. All these coordinators, they are well qualified. The coordinator of pharmacovigilance and drug safety was even awarded by NAFDAC. She's in collaboration with pharmacists in the unit, the nurses, and also the doctors. Whenever there are issues of adverse drug reactions, she's always called upon. And we fill pharmacovigilance report forms and send to NAFDAC. We also have the coordinator, drug information, research, and education. This coordinator is a well trained personnel, and he has about 27 publications online. And he's involved in training of intern pharmacists, pharmacy students from University of Jos, and also postgraduate pharmacists of University of Jos, and also pharmacists that are on IT. Sorry, pharmacy students on IT. We have also coordinator clinicals. Our HOD is the one that coordinates the clinical activities of the hospital. The only unit that is directly involved in dispensing drug to patients is the OPD pharmacy. Is situated in the department. It's the only pharmacy that is unit that is situated in the department. Then we have these are the units that we have in the department. We have the small-scale manufacturing and quality control. We have the oncology pharmacy unit. We have male medical pharmacy. We have female medical pharmacy. We have O&G pharmacy. we have SCBU pharmacy, we have accident and emergency, and we have an aesthetic pharmacy, we have pediatric pharmacy, we have surgical pharmacy unit that covers the male surgical wards and also male orthopedic wards. We also have the surgical pharmacy 2, which covers the female surgical and orthopedic ward, and also the neurosurgery wards. Then we have the psychiatry pharmacy that supplies, drugs to the psychiatric patients and also are involved in activities in the psychiatric in the psychiatric unit. We have the Federal Staff Clinic. The Federal Staff Clinic is in the Federal Secretariat, and it attends to federal staff and also attends to outpatients within that community. We also have the IVF, and we have the pharmacy store. We have outstations. We have one in Mangu local government, that is Gindri. We have the other one in Lantan South local government. That is the snake center. Most of the cases that are coming from other hospitals, snake bites are brought to this center. And then we go on ward rounds with the doctors in those areas. Then we have, these are these activities of the OPD pharmacy. You can see pharmacists in the OPD attending to patients. Then this is the OPD pharmacy store. Then we have the small scale manufacturing and quality control. These are the things that are done in the small scale manufacturing control. We have compounding of extrapreneous preparation, most preparations that are off-label prescriptions. They are also involved in making hand sanitizer. During the COVID-19, it was Jude that supplied hand sanitizer to government house and ministries in the states. And also people coming from outside the state. They also produce liquid soap, sterile water, chlorine water, oral morphine, antacid, sulfur salicylic acid. Then these are the pharmacies there. Then these are the things they produce. We have the A&E pharmacy that service all these units. The A&E pharmacy. Then we have the O&G. You see ward rounds. We have ward rounds, student ward rounds, and also intern pharmacist ward rounds. We have preceptors, university that precept students of the University of Jos. These are the units that we have and the ward rounds that we do. These are the units. These are the units that we have. And then we have the anesthetic pharmacies. The anesthetic pharmacies, they prepare packs for different surgeries. Local anesthesia, for spinal anesthesia, for general anesthesia. Then we have these are the packs, these are the pharmacies. Then we have the IVF. Then we have the oncology pharmacy unit. In the oncology pharmacy unit, these are labeled. The oncology pharmacy unit, we give health talks to the cancer patients. We reconstitute cytosis drugs. Our reconstitution room is far from where the patients are administered the drug, so that patient will not be exposed and other staff will not be exposed. This is the reconstitution room. You can see pharmacists mixing the drugs. These are the pharmacists in the reconstitution room. These are university students that we attend to their group presentations. Yeah. So, thank you. These are our challenges. Manpower. You can see we are only 29 pharmacists, and we are trying our best to offer pharmaceutical care. And then lack of training is one of our challenges, and then lack of motivation by the management. Thank you.
Thank you, University of Jos Teaching Hospital. The larger the size or the larger the headache, the bigger the head, the larger is the headache. We have come to the end of this session. That is the last presenting teaching hospital. I want all of us to give a round of applause for all presenters. We thank you very much. Today we had a total of 11 facilities comprising 2 administrative, 3 secondary, and 6 tertiary institutions. Mr. Watson, please, I'd like to see you. After now. So, we have come to the end of this show. The results will be announced at the dinner. The prizes will be given in 2022 at the next AHAP hosting. That is our tradition. And I'm not going to break it. That is the way it is, and that is the way it's going to be. And let me recognize the presence of our national chairman, Dr. Kingsley Amibo. He just stepped in not too long ago. The AGM will begin at 2 o'clock. Thank you for the opportunity given to serve. If called upon again, we will be here. And if we call you, please oblige us. We'd like to thank the CPC chairman. We'd like to thank all the presenters and the members of the assessing teams for the inter-hospital as well as the poster presentation. We'd like to thank our brothers from the gun-carrying institutions, and we'd like to thank the technical crew. In spite of the challenges, we were able to pull through. But the beauty of it is that the technical things that we're talking about were carried out essentially by your colleague and my colleagues, pharmacists. It therefore means that we are growing and we have capacity to do quite a lot. So, on behalf of the national chairman of AHAP, the NEC, council, and indeed all of you who are seated on the other side of the podium, I'd like to say welcome, and I'd like to say thank you. God bless all of us. Have a nice day.
Please, can we put our hands together for Dr. Dan Orunwisi and all the assessors? Please, photographer. And the presenters.
All presenters, please come forward for a group photograph.
Please, for hospitals that need the pharmacist intervention form, please, you can pick a hard copy. The soft copy will be sent later. Pharmacist intervention form. Yes. Who's calling me now? Yes? Okay, sir. The snapshot, please. Yes.
Please, the forms will be distributed after the photographs. Please, Pharmacist Akelikuno, please stop that. Stop. Put that on hold. Put it on hold. Dr. Henry and Dr. Daraka, please come and collect your bags. Dr. Sain, Dr. Daraka, please come and collect your bags.